تمام.
ننزل لتحت. هلا لايف صار. نبدأ. We will start.
يعطيكم ألف عافية. أهلا وسهلا فيكم في رحاب جامعة دمشق. أستاذ العميد دوما بستعير منه الكلمة هي أجمل كليات الجامعة. إحنا سعداء اليوم باللقاء العلمي الثاني مع جامعة مانشستر. اللقاء العلمي هو بين جامعة دمشق كلية طب الأسنان وجامعة مانشستر بريطانيا. حيكون اللقاء العلمي اليوم معنون بعنوان عام هو Oral and Maxillofacial Surgery. معنا من بريطانيا الأستاذ الدكتور جوليان ياتس، هو أستاذ في جراحة الوجه والفكين من جامعة مانشستر، استشاري في المركز الطبي لجامعة مانشستر. مجالات التخصصية اللي بيهتم فيها هو الردود والتشوهات الوجهية وجراحة الفم ووجه الأسنان. عنوان المحاضرة حيكون الجراحات الإصلاحية المجهرية، تدبير تبعات وردود العصب الفكي السفلي والعصب اللساني، وهو موضوع مهم ومميز ولم يحاضر به سابقا في منطقة الشرق المتوسط. الأستاذ الثاني هو الأستاذ الدكتور محمد بدر، ماجستير وزمالة ودكتوراه في جراحة الفم وزراعة الأسنان، محاضر واستشاري في جامعة مانشستر. المجالات التي يهتم بها هي الجراحة الفموية عند الأطفال والجراحة تحت التركيب. سيكون عنوان المحاضرة هي الطعوم العظمية في سياق زرع الأسنان. الدكتور الثالث هو سفيرنا، السفير فوق العادة، هذا المصطلح اللي حبيت أقدم لك إياه، شيتي، دراسات عليا في جراحة الوجه والفكين، مسؤول الدراسات من جامعة مانشستر والمنسق مع الجامعة في بريطانيا، وهو جزء من الفريق البحثي في كلية طب الأسنان في جامعة مانشستر. المحاضرة مشوقة جدا بعنوان زركون أم التيتانيوم في زرع الأسنان. من الجانب السوري حيكون معنا الأستاذ الدكتور باسل براد، فخور جدا بوجود الأستاذ معنا، متشكرك جدا. الأستاذ باسل براد هو دكتوراه في جراحة الوجه والفكين من جامعة هامبورغ في ألمانيا، مدرس سابق في جامعة هامبورغ، واختصاصي في تصحيح التشوهات والانحرافات الوجهية والجراحة التقويمية أيضا، وهو اختصاصي من جامعة دمشق في أمراض اللثة وزرع الأسنان، وله العديد من الأبحاث المنشورة. الأستاذ باسل براد هو رئيس قسم جراحة الوجه والفكين وأستاذ موجود من الستاف في الكلية. فخورين جدا بوجودك. We are welcoming you all in Damascus University in such this meeting. We are introducing Dr. Julian Yats. He is a professor in oral and maxillofacial surgery. He works as a consultant in the Center of Manchester NHS Foundation, and he is a clinical. The clinical area of interest is facial deformity and facial trauma, oral and maxillofacial implantology. The lecture will be entitled "By Consequences and Management of Inferior Alveolar and Lingual Nerve Injuries." The second professor is Mr. Muhammad Badr. He has his bachelor degree and MSc and PhD from England. He is a consultant and honorary senior lecturer in oral surgery at University of Manchester. The lecture will be entitled Bone Augmentation, Grafting and Implantology. The third lecturer is our special ambassador, Dr. Shaukat Ashiti. He is a postgraduate resident in the Faculty of Dental Medicine in Manchester. He is responsible for postgraduate office at University of Manchester. He is his lecture will be entitled Zirconia versus Titanium, a New Era. It's a special thing to be talking. From the Damascus side, Damascus University, we have Professor Basil Brad. He is the head of oral and maxillofacial surgery here in our university. He got his master degree and PhD from Hamburg University, Germany. He was a vice teacher there, lecturer, and now he is the head of the department. He has a lot of published articles, and he is one of the staff. We are honored to have him today. We thank you all, and we have now, as a schedule we mentioned, we have a small overview by Dr. Basil Brad to come inside and go inside the topic we are doing today. We thank you all. It's a great thing to do, like in such circumstances between Damascus and Manchester University. Dr. Basil Brad, the audience is yours. You can start by sharing the screen or start talking. Take your time.
أعمل share. شكرا دكتور أنس. Thank you for your introducing. I'll start with Arabic language firstly, and then I will move to the English language. أسعد الله أوقاتكم زملائي أطباء الأسنان، أحبابي الطلاب، أعزائي المتابعين. يسعدني أن أطل عليكم من جامعة دمشق كلية طب الأسنان في لقاء مباشر مع زملائي من قسم جراحة الفكين في جامعة مانشستر في بريطانيا. الزميل البروفيسور جوليان ياتس الدكتور محمد بدر والدكتور شوكت شيتي في يوم علمي يتم فيه إلقاء الضوء على بعض النواحي العلمية المشتركة ما بين طبيب الأسنان الممارس وأخصائي جراحة الفكين. من أهم هذه المواضيع التي سنناقشها في هذا اللقاء أذيات العصب السنخي والعصب اللساني، حيث سيحدثنا البروفيسور ياتس عن أسباب هذه الأذيات وطرق تدبيرها ونتيجة ذلك على المدى البعيد. ثم سننتقل في الساعة الثانية من هذا اللقاء العلمي لنستمع للدكتور محمد بدر، وهو يعرض لنا وجهة نظر جامعة مانشستر في الطعوم العظمية والتقنيات المستخدمة لديهم في تدبير النسج الصلبة استعدادا لاستقبال الغرسات السنية والتعديلات التقنية ذات الصلة، كما سيعرض لنا مهاراتهم المكتسبة خلال فترة تدريبهم وممارستهم السابقة. بعد ذلك وفي الساعة الثالثة من هذا اللقاء سنتشرف بالترحيب بالدكتور شوكت الشيتي، والذي سيعرض لنا مشكورا خبرته في المقارنة ما بين مادة الزيركونيوم ومادة التيتان كمواد مستخدمة في طب الأسنان وخاصة الزرعات السنية، حيث طرأت في الآونة الأخيرة تطورات هامة، سواء كان ذلك على مادة التيتانيوم من حيث النقاء ومعالجة السطح، أو على مادة الزيركونيوم من حيث المتانة ومقاومة الكسر، حيث أصبحت هذه المادة مادة الزيركونيوم مادة هامة في صناعة الغرسات السنية، خاصة في المنطقة الأمامية التجميلية من الحفرة الفموية. سننتقل الآن إلى اللغة الإنجليزية لنقدم لكم تلخيصا عما سبق. Good evening, everyone, dear students and followers. I'm glad to meet you online from the Dental College of Damascus University with my colleagues from the departments of Maxillofacial Surgery, Manchester University in Britain, Professor Julian Yats, Dr. Mohammed Badr, and Dr. Shaukat Ashiti. Firstly, I thank my friend Professor Jaban for his opportunity for this meeting. Well, our scientific day highlights some common aspects between the GPs and oral surgeon. One of the most important topics that will be discussed in this meeting is the damage of alveolar and lingual nerves, where Professor Yats will explain to us the causes, managements, and consequences. Then we will move to the second hour to listen to Dr. Mohammed Badr, as he will tell us about the aspects of bone grafting and the techniques of hard tissue management receiving dental implants. Furthermore, he will tell us about the skills during previous training and practices. After that, at the third part of this meeting, we will be honored to welcome Dr. Shaukat Ashiti, who will speak about his experience and comparison between zirconium and titanium as materials used in dentistry, especially dental implants, where important developments have occurred recently. Titanium in terms of purity and surface treatment, zirconium in terms of durability and resistance. Particularly, it has become an important material for manufactured dental implants in a static area of oral cavity. Well, now I'm pleased to welcome Professor Dr. Julian Yats. Julian, I am Dr. Basil Brad, head of Department and the Clinic of Oral and Maxillofacial Surgery, Damascus University. It's our first meeting, but surely not the last one.
Hello, hi.
Hello. Julian, I greet you. I greet all my colleagues in Manchester University. I hope that these scientific activities will be repeated between us more and more, including what benefits our students who are now following you with longing and warmth.
Thank you very much. I hope so too.
Julian, we know that the nerve injuries are an important topic because of the healing difficulties. We have 45 interesting minutes to benefit your experience about nerve injuries management. You have the mic now, Julian.
Thank you. I will just share my screen and get my presentation up. So welcome everyone. So first of all, I'd like to thank Shukat and the organising team for inviting me to give this talk. I know Shukat has been one of our outstanding students in Manchester, and he was very keen to get this collaboration going and to try and have some sort of joined up thinking and teaching. So it is a pleasure to be invited to give a talk. So today, what I'd like to talk about is basically iatrogenic damage to the inferior alveolar and lingual nerve, primarily focusing on the etiology, the management, and patient-related outcomes. Well, before I dive into that sort of topic, I thought I'd give you a little bit of background as to where we are. So for those of you that are familiar, you probably don't need telling, but for those of you that aren't, what we can see here is this is the map of the UK. We can see that Manchester is around here, and Manchester is very important because it has two quite significant football clubs. We have Manchester United and of course Manchester City, but actually they're not the most important football clubs in the UK. You'll probably see here there's a city called Sheffield. That's where I'm from and that's where I live, and I travel over to Manchester. And of course we all know that the best football club in the world is Sheffield United, which is the oldest professional football club in the world, founded in 1889. So for those of you in any doubt, these are the Blades, and they are newly promoted to the Premier League this year, and they're doing rather well, although whether we make it into Europe, I'm not too sure. But anyway. Near to Manchester, there are some good sites. Of course, we've got in between Manchester and Sheffield, we have Chatsworth House, which is a nice sort of stately home, which you can go and visit, and that's sort of in and around the Peak District in the north of England. If you're slightly younger than me, there are places like Blackpool, which is on the northwest coast, which is a bit lively, but that's quite a good place to go and visit as well. And there's lots of other places. And of course, you have to remember, we're only probably a couple of hours or so away from London as well by train. So there's a lot to do and see, and there's lots of things that are nearby us. So moving on, today, I'm probably going to talk about the anatomy, the incidence of injury, the clinical problem, the financial cost of nerve injuries, the pathophysiology, like what causes the problem, the evidence behind it, clinical evaluation and assessment, the cause of injury, patient-reported outcomes, and prevention. So why do we have an interest in the trigeminal system? Well, we know that the trigeminal nerve is the nerve that innervates the face and the oral cavity with the sensation, and nerves within the trigeminal system do behave differently to those of the spinal nerves. So they're the nerves that come out of your spinal cord and vertebral column. And we know that from various studies, and it is an important nerve which we are intimately related with. So why do we have an interest in the inferior alveolar nerve and the lingual nerve? Well, primarily because it can undergo, or either of those nerves or both of them can undergo iatrogenic damage following procedures such as the surgical removal of lower wisdom teeth or following trauma. And we'll see later on in some slides that there's actually other causes as well. There are a large number of these and other operations undertaken by the specialty. So we have general dental practitioners or clinicians in primary care that will undertake these types of extractions, and for the more complex ones, patients get referred into hospital. And in fact, the removal of lower wisdom teeth, third molar teeth, is probably one of the most common procedures undertaken in the UK today. As dentists and oral surgeons, we work closely or in close proximity to branches of the trigeminal nerve, and we have the potential to damage them, and we do, unfortunately. And we do have, or as a consequence of that, we have a small but sufficient or significant number of patients that do sustain injuries to the lingual nerve or the inferior alveolar nerve. And although as a specialty or as a profession, because we do a lot of these procedures, we almost become quite partisan to them, you know, it's sort of routine. What should be remembered is that actually this is a significant clinical problem. not only for the clinicians who are treating these patients, but more specifically for the patient. And here's an example. So this is a little highlight of the clinical problem. We had a lady here, Mrs. A, in 2011. So she had her wisdom teeth removed and is in agony 6 years later. So this is a patient who had wisdom teeth, was reported and went to the press to sort of detail her ordeal. And what has been stated by this patient is that you know, she could even feel the pain if she brushed the cotton wool across her face. And she suffers from a constant burning pain on her chin and on the right side of her face. And to her, this means that as she's, you know, as a devoted mother, she has to avoid any sort of close physical contact with loved ones. And ultimately, she says she's in pain all the time. The real difficulty and the worst thing is that she can't bear contact with anyone in and around her face. So this is one patient who's obviously had quite a hard time following the removal of a lower third molar tooth. Here's another case, and again, it just highlights, you know, the profound effect these problems can have on some patients. Now, this isn't really, you know, a high standard medical or dental journal. It is sort of a bit of a gossip sort of magazine from a few years ago, but it just shows here that this lady, Tina, you know, she can never enjoy kissing again, and that in fact she felt so low she wanted to kill herself, and sometimes she still wants to end it all. So although we sometimes brush the conversation about damage to the lingual nerve and the inferior alveolar nerve to one side, when it does happen, it can have quite a devastating effect on these patients. So when it does happen, we've seen the personal cost there to some patients, not all, but some. What's the financial cost? Well, I don't know what it's like in Syria or many other countries, but in the UK, this is becoming an increasingly sort of problematic area of litigation for clinicians. What we see is that, you know, with various injuries, that it becomes expensive for the indemnifiers or the insurance companies that help support clinicians. So, for example, we have a case here where an oral surgeon transected the lingual nerve in a 29-year-old during a wisdom tooth removal. And basically, the patient complained of complete numbness and loss of taste on the entire half of her right tongue. And essentially, this was a jury award of $2.3 million some years ago. Interestingly, that the patient wouldn't have got that. What tends to happen, this was in America, and what tends to happen is they tend to go for multiples of money, and this would have been probably settled maybe for a quarter to a third of that amount, but it's still a significant amount of money that insurance companies have to pay out. Another case here, again, general dentist performed the surgical removal of a lower third molar, and the following morning the patient began to experience numbness and burning or a tingling sensation on the right side of the mouth. Unfortunately, corrective microsurgery was unsuccessful, and the bony plate next to the path through which the lingual nerve travels was fractured. So it looks as if there was quite a traumatic extraction there, and again, a jury award of, you know, $750,000. So very expensive. In the UK, we're not quite at that level yet, but you know, there are certain levels of compensation that are paid to patients that suffer from damage to these nerves. So from a wisdom tooth extraction nerve injury, something like a permanent abnormal sensation, it will cost an indemnifier somewhere between £4,000 and £50,000 to settle that case. This isn't related to negligence. This is just purely about suffering harm that you otherwise should not have suffered during an operation. And of course, you know, damage is awarded, you know, for lots of other things, you know, and to put that into perspective, in the UK, if a relative dies in hospital due to medical negligence, the payout for that is usually about £13,000. So we can see that actually patients that are having to put up with the symptoms and the problems relating to damage of these nerves, because they are probably going to be burdened with those for the rest of their life, end up having quite significant payouts by way of compensation. So where is the nerve? Well, we can see here that not too far away from lower third molars, we can see in this little video clip here that this is at the base of a socket of a removed, you know, surgically elevated lower third molar. And you can see that that's a sort of a branch of the ID nerve down there, just at the base of the socket. So you can imagine that if you get excessive bleeding or bruising, or if you displace the tooth inferiorly before it elevates out, that nerve can get a bit of a squash, and that can cause the problems. You can also see the position of the long buccal nerve on the buccal aspect near the alveolus. Here's the inferior nerve, and this is the lingual nerve. When it comes to the lingual nerve, we can see here that this is the site of a surgical removal of a lower third molar, and we can see that the lingual nerve just passes just under the periosteum, well, actually superficial to the periosteum, in the connective tissue, and that is probably, when that soft tissue lies down, it's probably at the level of the alveolar crest. And we know from anatomical studies that the nerve can lie anything from 2 millimeters above the anatomical crest, the alveolar crest, to about 5 or 6 millimeters below the alveolar crest. So there's quite a lot of variation there. And of course, we sometimes do lingual flap retraction. Sometimes we might slip the burr, whatever. And of course, if the nerve is that close, it is susceptible to damage. So what are the incidents of inferior alveolar nerve damage? Well, we know that the inferior alveolar nerve supplies externally, anyway, the chin and lower lip on the ipsilateral side, and the lingual nerve supplies the ipsilateral half of the anterior 2/3 of the tongue. So depending on which paper you read, you can see that there's a big variation, or a large variation, of incidents of injuries. Anything from sort of 0.5, 1%, 1.3, all the way up to, some authors have reported, 5, 6%. Rude there in 1983 reported 7.5%. And again, it all relates to the technique that's used. But ultimately, this is a range of altered sensation. And when you get down to the crux of permanent altered sensation, you are looking at about sort of 0.3 to 1% of permanent damage stroke altered sensation. And what we have to remember is, within that scope of permanent damage, it can be anything that is from total numbness all the way to very minor abnormal sensation that the patient may only be aware of if they're walking on a cold morning, or they go for a swim or splash their face with water. So there is a spectrum of altered sensations. And of course, we all meet surgeons that say they don't get any injury. And obviously the people that publish these reports are suboptimal, or should we say bad surgeons. But I say to those people, let someone independent evaluate your figures and publish them. But at the present, these are the quoted references. Moving on, the lingual nerve. Again, we have a range of incidences where the frequency of a nerve injury varying from sort of 0.1 all the way to 22%. And of course, when it comes to permanent damage, which relates to abnormal taste sensation, not being able to feel the side of the tongue, maybe having some dysesthesia associated with either the site of the injury of the tongue, permanent damage is in about 0.5 to 2%, just depending on which report you read. You may ask yourself, well, why is this up at 22%? Well, I think this was, where they took all their surgical options, and one of the arguments was that this related to not only quite extensive lingual flap retraction, but also the use of lingual split technique. So what's the clinical problem? Well, most patients can deal with an element of post-operative discomfort or post-operative pain, even infection, as long as it resolves. But it's usually the long-term outcome of these injuries that is the problem with patients. So at the very best, you may get a very temporary element of abnormal sensation, whether that's tingling, can't quite feel things, or more excessively dysesthesia for a short period of time. But in its worst case scenario, and we see these quite a lot, is that patients can get quite intense tingling that's continuously in the background, along with an associated burning sensation or a dysesthesia, as if patients often describe it as someone having a hot poker or a constant presence of chili powder on their tongue or the site of injury. And of course, you can imagine that this is quite upsetting for many patients the longer that it happens. So we know that nerve damage can lead to significant problems, including paresthesia and dysesthesia, with both nerves. And the problem at the moment is that we have no fully effective way of managing these patients. We sort of have a toolbox of treatments we can provide, but there's no one way of managing all patients. And the way we have of managing these patients isn't guaranteed to get them back to 100% normal. And because we'll talk a little bit about that later when it comes to patient-related outcomes, about expectations. This picture here, you can see that this is actually a neuroma in continuity. So this is a patient who was operated on a couple of years ago. There's the first molar, the second molar. This is the lingual nerve. And you can see that this should look like a nice, thin, shiny, nervous structure, whereas actually it's all sort of matted, it's got fibrous tissue, it's got connective tissue. You can only just about see the central stump. The peripheral stump or the distal stump seems okay, but this is a tangle of fibrous and scar tissue along with axons and nerves, so hence a neuroma in continuity. Oh, apologies. So what causes this? Well, it's still unclear, but what we do know is that there are peripheral mechanisms and there are central mechanisms. So when you damage a nerve, there are things that happen at the site of the nerve injury, but sometimes there are also things that happen more centrally within the central nervous system as a consequence of the damage of the nerve peripherally. Ultimately, when you talk about nerves, it's usually about a combination of things, action potentials, and the abnormal way in which nerves work. And so what can happen is you may have what is otherwise a quiescent nerve in normal function. It just sits there and it fires off action potentials if it's either receiving sensory stimuli from a peripheral nerve ending, or it's providing motor action to an effector organ if it's a motor nerve, but it's all undertaken by action potentials. However, when nerves get damaged, these action potentials start to play around, and what you tend to get is an element of what we call spontaneous discharge. So what that means is that nerves that would otherwise be quiet, they wouldn't be firing action potentials unless they were stimulated or they were directing signals towards an effector organ or something like that. They start firing off automatically, just on their own. The other thing that you can get is a thing called mechanical stimulation. And again, so what that means is nerves that just sit there quietly, if you rub them when they're injured, they start shooting off action potentials. A similar analogy to that is if you hit your ulnar nerve or your funny bone. So if you bang the side of your elbow on a sharp object, you'll get shooting feelings down into your little fingers and the side of your hand. And of course, that's what happens. And of course, your brain interprets that as quite a nauseous or quite a painful sensation. So that's what happens when you get abnormal mechanical stimulation. You just get this abnormal sensation that goes along with it in sensory nerves. And these changes within the damaged axons are thought to contribute to the sensory disturbance, especially dysesthesia. So if you get a combination of spontaneous discharge and mechanical sensitivity at the site of nerve injury, this can contribute to quite significant altered sensation. This is just an example. We have here two, these are electrode recordings from axons. So these are raw data recordings from damaged axons. And what you can see here is the action potentials firing off spontaneously. And down here we can see that the same nerve, when the area of injury on the nerve is rubbed, you can see that the number of action potentials increases for the duration of the stimulation. So otherwise this would be a quiet nerve that's firing off action potentials, and when you rub it or touch it, it fires off even more action potentials. And you can imagine that all this information from a peripheral injured nerve, such as the lingual nerve or the ID nerve, shooting off into the central nervous system, and where your brain makes sense of all this information, actually can't recognize these. And usually what happens is it is recognized as quite an uncomfortable, abnormal or painful sensation. So why does this happen? Why do we get this abnormal sort of firing off of action potentials? Well, we don't know really, but people have looked at things such as the accumulation of neuropeptides. So these are molecules that are essential for the normal functioning of nerves. You might get abnormal collections of ion channels, such as sodium channels or potassium channels. You get morphological changes in the nerve. When they're damaged, you get the formation of scar tissue, and you get chronic inflammation and the presence of foreign bodies. So previously, I've looked at these, the causations of these injuries and what molecular mechanisms there are that can cause the problems. And we've looked in both in vivo work and we've looked in human samples as well. And what we've done investigations into is different injuries, different time courses, the accumulation of neuropeptides, the accumulation of ion channels, changes that happen histologically or morphologically within the nerve, and possible treatments. So what we know is that once you've damaged a nerve, that the action potentials, the abnormal firing off of spontaneous discharge, starts within about 24 to 48 hours, and it is prolonged. It is dependent on the nature of the injury, and some injuries cause a lot more of this discharge than others. What we also discovered was that it does decline in time with inferior alveolar nerve injuries, but with lingual nerves, the effect lasts for a lot longer. Here's a couple of graphs just to demonstrate this. What we see here on the left is spontaneous activity. You can see the light blue or the light purple is the inferior alveolar nerve, and the dark purple or the dark blue is the lingual nerve. And you can see with time that the level of spontaneous activity sort of tapers off with the ID nerve, but it's consistent with the lingual nerve. And the same with the mechanical sensitivity, it sort of peters off with the ID nerve, but it's persistent with the lingual nerve. We actually did work beyond this for 6 months, and you get the same pattern, whereas it tapers off for the ID nerve, but is consistent for the lingual nerve. This is just an example. I won't bore you with this, but this is just some immunohistochemistry of a sample of neuropeptides at the site of a nerve injury. So this is where we've squashed the nerve. This is constricted with a suture and going about its daily business. This is an ID nerve. Oh, sorry. This is an ID nerve. And what you can see here is actually the accumulation of substance P neuropeptide. And what we know is that certain neuropeptides, such as substance P and CGRP, are associated with levels of nociception, i.e. painful stimuli, but conversely others, such as neuropeptide Y, enkephalin and others, are associated with an analgesic effect. So they collect at the injury site, and so you can imagine that they may play around or they may influence the development of action potentials. The same can be said with sodium channels. Again, this is some immunocytochemistry, and what we know is there are numerous different types of sodium channels, and we did some work looking at various types of or subtypes of sodium channels to see whether the accumulation or the downregulation of these channels, either within the nerve, which is the picture here on the left, or the trigeminal ganglion, which is more centrally in the central nervous system, whether they were related to sort of increased levels of spontaneous discharge. Unfortunately, what we found was that there was no real correlation in human samples. So maybe sodium channels aren't quite as important as neuropeptides. Sometimes we get histological changes. We get chronic inflammatory infiltrate, and because that can play around with how nerves function, and we can actually see bits of metal. So within the neuromas that we've sampled from human tissue, these are chunks of metal. And of course, you can imagine you get a foreign body reaction, it's within a nerve, and the nerve probably won't function properly. And again, we get morphological changes. So this is at an electron microscope level where, when nerves are damaged and they try to recover, they are always smaller. They have higher levels of exposure of the epineurium. So the surrounding Schwann layer isn't as thick, or it's interrupted compared to normal nerves, and you get closer apposition of the nerve. So it may well be you get crossover stimulation of nerve axons due to the decreased level of myelination once they've tried to recover. So all these things probably play a part in the development, I don't think we can pin it down to one thing, and it's more than likely multifactorial. But work is ongoing with colleagues of mine that I've worked with in the past in Sheffield, looking at the etiology of dysesthesia and abnormal sensation following injury to those nerves. So the cause of injury. Well, we talk a lot about wisdom teeth, but I can tell you it's not just about wisdom teeth. So what you will often do is you will see journals that quote frequencies or incidents of nerve injuries of either the lingual nerve or the ID nerve relating to the number of wisdom teeth that have been removed in that hospital or that clinic. I tend to look at it, that gives you some valuable information, but I think it's important to look at it another way. Because it's not only related to wisdom teeth. It happens in other ways as well. So this is just a sample. This is a collection of patients that I've seen. I keep a database of patients. And this just happened when I started working in Manchester. I just collected data on the first 100 consecutive patients that attended with nerve injuries. So they weren't patients that had wisdom teeth removed. They were patients that just presented with nerve injuries. And I needed to find out what was the cause and what we were going to do with them. And what we found was something quite startling. So actually, if you look at the spread of causation, yes, you do have about 45% of patients. So this was the first 100 patients that came through that suffered, so that was 45, inferior alveolar nerve injuries, accounted for 26 of those, lingual nerves, 19 of them accounted for lingual nerves, and in 7 cases, both nerves were injured. Simple extraction of lower wisdom teeth. Again, 27 of those. There were 10 that had damage to the ID nerve, 17 that had damage to the lingual nerve, but 6 that had damage to both nerves. Dental implant placement. Well, obviously, I'd like to think you wouldn't get damage to the lingual nerve placing a dental implant, but they were all related to the ID nerve. Very interestingly, though, simple extraction of lower second molar teeth. Yeah. So that's the one anterior to the third molar. There were 10 patients that suffered injury to the ID nerve or the lingual nerve. And then, of course, just with injection injuries, there were 4 patients that had some form of injury with the ID nerve. So interestingly, how can we explain these? Well, I think from the outset, damage to the inferior alveolar nerve on most occasions is probably not something you have much control of. You can identify high-risk patients, but because it's within the socket, around the bone, within the alveolus, you have very little influence on how that might get damaged. You might have a tiny bit of influence, but not much. When it comes to lingual nerves, I don't think we should be seeing those, to be fair. There are techniques you can employ to avoid that nerve. And interestingly, simple extraction, whether that's an elevation or forceps, and you've got injury to the lingual nerve, same with simple extraction of the lower second molar, that's either stretching of the mucosa with the beaks of the forceps or grabbing of the lingual tissues as well as the tooth when you're coming to extract it, the tooth, and just grabbing hold of the lingual nerve, which is within those tissues. As we saw earlier, you can see that the height of the lingual nerve is very variable, and on some occasions it can be above the height of the alveolar crest. So there's a good spectrum of causation there, some of which could probably be controlled. Others, I think, can't be. So what do we do clinically and what do we measure? So when we get patients that attend with these injuries, we use a specific nerve injury questionnaire. We do a qualitative evaluation, so that's patient-led, and we do a quantitative evaluation, which is clinician-led. So when we look at the quantitative evaluation, we look at pinprick, soft touch, 2-point discrimination. They're the sort of the basic levels of assessment we do. We undertake patient education about consent, the surgery and expectations, subjective evaluation, and patient-led interventions. This is important because no amount of quantitative evaluation, it gives you a baseline measurement and measurements of improvement, say if you decide to do surgery on the patient, but it's actually, that bears very little relation to how the patient feels. There's often patients that can actually not feel much and have quite profound paresthesia or anesthesia, but it doesn't bother them that much. But conversely, you might get a quantitative output, which is quite reasonable, and you think, oh, that's okay, they can feel quite a lot, but it affects the patient significantly. So we use the questionnaires when we do these, and we just collect the data for them. So these are just designed on our clinic. It is specific to that nerve injury. We do some very simple testing, just with a sharp probe, some cotton wool buds, and a 2-point discrimination testing wheel. We've moved on from this now because actually there are issues with cross-infection and actually having to get hold of these. So we usually just use a set of college tweezers now, and it's, you know, that's about 10, 11 millimeters, the spread of the end. And we just say, can you feel 1 or 2 points of discrimination? So the subjective evaluation, you know, we ask them, how does it affect you in your everyday life? How do you feel on a day-to-day basis? What makes you feel that way, you know, or better, worse? And the options we give are usually, well, let's wait and see with regular reviews. Can we do therapeutic agents? Is surgery appropriate? Or can we use cognitive behavioral therapy or clinical hypnotherapy? There's no one rule fits all patients. And so it may well be that we've had a patient that sustained an injury to one of those nerves. We get to see them on clinic a few weeks or a couple of months later, and actually the patient reports that things are getting better. So what I've learned with time is that Mother Nature is quite good, and if you just leave things to settle and recover on their own, sometimes patients can get quite good results. They may never come back to normal, but it may be good enough for them. If patients have got burning sensations or dysesthesia, it may well be that or intense tingling, we may try therapeutic agents first. And that may just be because they don't want surgery. The trauma of having their wisdom tooth was traumatic enough for them, and they don't want more surgery. And it is amazing how many patients say that it was, you know, one of the most traumatic experiences they had. It was a difficult extraction. It took a long time. They didn't think the operator knew what they were doing. They used a drill for a long time, and it was painful. And so that all goes hand in hand sometimes with the outcome of damage to those nerves. Surgery, if it's appropriate, surgery is, the idea of that is you go in with an open mind and you treat what you find. Usually surgery is reserved for patients that aren't making progress and things aren't improving on their own, patients that have quite significant neurosensory deficit, and patients that have quite a lot of tingling and the presence of dysesthesia. You have to take all of those independently. So it may well be that if you've got a patient that has quite a lot of sensation, but quite a lot of dysesthesia, you might go down the therapeutic route. If you've got a patient that's got quite a lot of dysesthesia but can't feel a lot, then it may well be you opt for surgery. What is important to say is that in a significant injury where patients have significant neurosensory deficit and they have levels of tingling and dysesthesia, they must always be advised that surgery will not cure them. We would hope to make them better, but they may not get back to 100%. They will probably not get back to 100%. And there's the odd chance, very rare, that we may make things worse. So we have to be very truthful and honest with our patients and say, there's a small chance that you might not get better at all, and there's an even smaller chance that we may make things worse. So treatments, yeah, so we can look at agents affecting structural change, membrane stabilizing drugs such as carbamazepine, surgery, cognitive behavioral therapy and such. So that's the sort of thing we can offer. Previously in work, what we've looked at is the effect of steroids, corticosteroids around the site of injury, and what we saw was that actually in vivo work, long term, it actually didn't make any difference to the spontaneous activity. Sorry. However, it did reduce the level of mechanical sensitivity. But that's one component of the abnormal behavior of the nerve. So as a package, what we found is it probably doesn't work that well. Carbamazepine, it's sort of like a membrane stabilizing drug. It's used for conditions such as trigeminal neuralgia and epilepsy. And again, what we found was, these are some raw data recordings from 2 spontaneously active axons or nerve fibers. And again, for every sort of nerve fiber where the carbamazepine did reduce the level of spontaneous activity, there was another axon or unit that didn't. It just carried on. Carbamazepine is a sodium channel influencer, shall we say? I wouldn't say blocker, but sodium channel influencer. And so we know that there's lots of different sodium channels. The combination will be different. And so actually its effect on some injured nerves may be limited. Surgery. So again, do we do it immediate or delayed? Do we suture or graft? do we use steroids to reduce scar tissue? I think it's generally accepted that actually, if you witness a section of a lingual nerve or an ID nerve, at that time, some attempt should be made to repair it at that point. What we know from experiments and other work on nerve repairs on humans is that the sooner you get it repaired, if you witness it, the better the outcome will be. However, if patients aren't finding their way to you for 2 or 3 or 4 or 6 months because their regular dentist has been keeping an eye on them, what we've found in animal work and experimental work is that there's no difference in the outcome following a delayed approach. It's variable, but it doesn't make much difference. Do we suture or graft? I tend to avoid grafting if we can. I much prefer direct apposition with epineural suturing. And again, I think the laboratory work and other studies on other peripheral nerves have shown that direct apposition and suturing is probably the best way forward. And should we use steroids to reduce scar tissue? I think we should. Does it change the outcome? Probably not. But I think sometimes what you don't want is all that connective tissue or scar tissue growing back into your repair. So I think we'll whiz through this because I think I may be the next 15, 20 minutes running out of time. So what we do is, though, when we do a repair, is we apply laboratory-based principles such as neuroma excision, stump mobilization, direct reapposition, and suturing. And basically we have a growing database of the outcomes, and we evaluate patient satisfaction and quality of life. So I've got a little video here of a lingual nerve repair. This is the right lingual nerve repair. So we would generally lift up quite a large mucoperiosteal flap. We would expose the lingual aspect of the flap. So we bring this incision all the way around to the first or second premolar and extend it and retract. We would then excise or incise through the periosteum, and we'd find the nerve. Now, this can be quite difficult sometimes because there's a lot of scar tissue there sometimes. So what we tend to do is look for the central stump, and then once we've found that, we'll look for the peripheral stump. So we can see here that this is actually, I think, there's the central stump. There's the distal stump. This is all the scar tissue that's wrapped around the nerve. There's the central stump. So this was actually a nerve that was transected and probably had a few fibers between the central and distal stumps. So we mobilize it. We sort of try and stretch it slightly if we can. And the more you free this up from its surrounding connective tissue, the more it'll stretch. So there we are. That's the central stump. There's the distal stump. We would clean all the sort of fibrous tissue from around it. And then what we would do is, so we'd see if we can get direct apposition. We clean the little bits of scar tissue at the end or the affected areas. And then what we do, we'd spend our time just suturing this together. So we can see here that, again, just clearing all that nasty fibrous tissue away. This is the first stitch. This is always the tricky one because you've got to get the right orientation. So we try and get one just on the superior aspect of the peripheral and the central stump, and try and do this. Again, it's all done under a microscope, and actually the most important person with this operation is the assistant. The assistant needs to be able to retract well, not poke the aspirator tip where you don't want it, and just generally help you with the operation. See if I can move this on a little bit more. The orientation is potentially quite important, and although at a microscopic level we're probably not as accurate as we can be, at a macroscopic level you have to remember that within the nerve, not only do you have general mechanosensitive fibers, which are general sensation to the tongue, but you also have gustatory fibers, which are important for taste. So I'm not pretending that we can align these up perfectly, but some sort of general appreciation that the superior aspect goes to the top and the inferior aspect goes to the bottom will help to align those different subpopulations of fibers within the nerve. So we're just finishing off here. We normally put about 6 to 9 sutures around the nerve to complete it off. And then this is the end repair. And you can see that this is just brought the ends nicely together. And hopefully that will provide some form of improvement for the patient. Just a very quick video now about the inferior alveolar nerve. Again, we can't really do direct apposition for those nerves. All we can do is perform what we call a neurolysis, and that's because all the nerve is within a bony canal, and to try and release those distal and central stumps is impossible, really. So we just use very rudimentary equipment, just a burr. We go down mesially, distally to where the third molar was removed, and just score the buccal plate as if this is exactly the same as a Ramus graft if you're using this for implantology. And then what we do is we remove that, and then we use basically a smooth diamond burr so that we don't catch the soft tissue if we come across the nerve, and we just gently remove the cancellous bone within the portion of bone that you've removed. And you can see here that you often get that. There's a piece of fibrous tissue that's coming up through to the alveolus and the socket, which is where the tooth was removed. So what happens is the soft tissue heals, and some of it can go down into the socket and wrap itself around the ID nerve. So we're just freeing it from the lingual aspect of its surface, and you can see the scar tissue. That should be, this is normal, and this is all neuroma. And what we do is we get rid of any bony interferences. Can you see that this is dilated here? So we smooth off the lingual aspect, lingual plate, and then we remove any scar tissue, free it up, neurolysis, and then we just let the nerve rest there to recover. And what we don't do is put the bone block back. We just leave it to recorticate. So the outcomes that we measure are causes of injury, the quality of life, qualitative interview questioning, has the management been effective, and a subjective overall. So we're just going to rush through this now. A good quality of life tool is the oral impact on daily performance. It's derived from the WHO's International Classification of Impairments. It's a good tool for for measuring the effect of or consequence of an injury on a patient in their daily lives. Basically, it's a combination of the frequency and severity scores and the outcome associated difficulties in performing daily living activities. So these are the sort of these relate to the gender of the patient and the type of nerve that's been injured, or the nerve that's been injured, and these are the parameters. So these are the daily activities that basically are related to injury of this type of nerve. And what we see here, I'll just tell you now that how this is calculated. Anything over 2 is having an effect on the patient. Okay, so overall, when we do these questionnaires, male patients aren't generally that bothered about the abnormal sensation. However, female patients tend to be slightly more affected by it. Interestingly, the inferior alveolar nerve causes problems, so that affects patients, but the damage to the lingual nerve has more of an effect on patients. And if we move down to the other parameters, so what daily activities does it really affect patients? How does it affect them? Well, eating food, well, that would affect me, I can tell you. So eating food, 3.4, that's, it affects them eating food significantly. Cleaning their teeth, not really. Sleeping and relaxing, not really. Emotional stability, so it plays on their mind on a day-to-day basis. And look at this, enjoying contact with other people, whether that's, cuddling your children, or, being close to relatives or whatever, that affects people. So we can see that the quality of life of patients is affected. Most patients, when they have treatment, usually feel that it's been a benefit. We don't offer surgery to all patients by any means. Just sitting down and educating them and explaining to them why this has happened goes a long way. Adjusting their expectations. Everyone goes in with the expectation that there are no potential complications with any operation. It's important to educate patients that actually some operations do have problems associated with them through no fault of anyone. They just have side effects, for want of a better word. There's no correlation between the delay in surgery and intervention and outcomes, but on balance, improvements are achieved. So on the whole, offering surgery where it's indicated, you do get improvements. Severe dysesthesias do have disappointing results. Female patients are more willing to seek surgical intervention, and lower third molars are not the only cause but it does add to the treatment dilemma. So you can look at your quantitative outcomes, whether it's your 2-point discrimination or your response to soft touch. You can look at other parameters. The bottom line is, when patients have had surgery, you want to know, was it worthwhile? And so sometimes you just can't get away from a subjective evaluation. So on a visual analog scale, you can ask patients from 0 to 10, my operation to help you with your nerve injury, was it a total waste of time, or did you get the perfect outcome? And what you can see here, that because it's a bit bimodal, the median output is about 7.5 to 8. Okay, so actually, sorry, the mean, yeah. So although it should be measured with the median, if you take the mean, it is about 7 to 8. And what that means is that on the whole, that's a pretty good indicator that the treatment you provide, the surgery, improves things. It may not make things 100% better, but the patient feels, satisfied with the outcome. Of course, there are some patients that thought it was a total waste of time. We can't acknowledge that. Then it sort of takes a dip. And there were a few that thought it was the perfect outcome. That's not to say they got 100% better. That's just to say we probably, in this group of patients, we met their expectations. So prevention of complications. We need to know that there are risks associated with all surgical interventions, and patients need to be told that. We need to minimize those risks. So we need to be good operators. We need to be considerate operators. We need to, be skillful. No amount of planning or investigation. So I often get asked, would you take a cone beam CT here? Would you or not? No amount of investigations makes up for suboptimal or poor surgery. I think inferior alveolar nerve injuries are something that we don't have much control over, as I said before, because the nerve is within the bone. However, I don't think we should be seeing lingual nerve injuries. That they are avoidable. And patient education and expectations are often ignored. So the last few slides, how do we prevent? Well, of course, you can have 2D imaging, you can have 3D imaging. Is one better over the other? All I can say is there's been lots of work, lots of publications, and then there's this Ascendant text lower third molar review. This looked at all the evidence up to the point of this publication about evaluating third molar roots and the proximity to the ID nerve, with cone beam CTs versus two-dimensional imaging. And the outcome of that review was having a cone beam CT makes no difference to the incidence of nerve injuries. Okay, so you have to answer the following questions. Is it going to give you additional information? And is it going to change the way you do your operation? This was a paper that I published with one of our, actually it was an undergraduate student a couple of years ago at the time, about different procedures and what you should consider when you talk about surgical removal or coronectomies. And of course, there are other things as well. The importance of addressing patient expectations. This is an osteomyelitis where there's been a fracture of the mandibular body in and around the lingula and the mandibular foramen. Should the patient expect anything less than a numb lip? No. So the patient needs to be educated that that's a significant problem associated with the osteomyelitis, and it's probably not going to get better. Again, enucleation of quite large cysts and facial trauma, we need to educate the patients and just be honest with them and say, there are side effects to certain injuries and operations that you can't improve. Last couple of slides now. It is important to address patients' expectations. We need to sort of say that actually, just because we can do an operation, not everything is going to be okay. This was an interesting case with someone who said that was a drill bit or something, or an endodontic file, that was it, that was extruded through the apices of this tooth. That wasn't the case. Actually, it was a silver point that we used to use years ago for root canal treatments, that the tip of it had probably got grabbed hold of by this cystic growth and dragged it down to the nerve. So what we did was we went in to try and save this tooth because the patient didn't want to lose it. So we extracted the tooth, we enucleated the cyst, we attempted to remove this, but it was too close to the nerve, and we did an apicectomy. So we did an apicectomy whilst the tooth was outside of the mouth, and put it back in, and it seemed to heal. It worked. Unfortunately, we tried the same thing with the lower secondary one and it didn't work. Actually, not because this didn't work, it's because the crown fell off and it was unrestorable. This is an interesting case over here. Root canal treatment that had gone through the apex of the tooth, irritating the nerve. Quite a small insult to the nerve, but the patient had a torrid time afterwards. And even when we tried to remove that medicament, didn't make any difference to the patient. Okay, so I think I think my time's done. Apologies for being overrunning slightly late. Patient expectations though, do we need a cone beam CT here scan? I don't think so. It's close, but it's not really encroaching on the upper border. But the patient will be sore, will be achy after the procedure, but shouldn't really expect to have to deal with a nerve injury. What are we going to tell this patient? Actually, you're more than likely going to have a nerve injury because of the intimate relation of this nerve to that tooth. In both cases, neither of them did, but it's about addressing their expectations. Also, know your limitations and know when to stop. You know, this is a case that presented, you know, patient carried on, had some implants on one side, had some more on the other side, transected the nerve, injury got infected, osteomyelitis, pathological fracture. So again, can we improve the situation for this patient? I don't think so. There's no amount of operating on that nerve or those nerves that will rectify that problem. And we see this quite regularly with patients that have had implants. So again, just be careful. So finally, on the last couple of slides, we just need to be aware of not only our actions, but also our inactions. So I don't know what it's like in Syria. I don't know what it's like in Damascus, but there is a trend over the last few years that patients don't want to seek operations for problematic wisdom teeth because of the fear of a nerve injury and altered sensation. However, in contrast, you have patients that are apprehensive about proceeding. But this is a case back in 2017, attended our accident and emergency department, Manchester Royal Infirmary, with a large bilateral submandibular swelling, attended by self-referral as being sent away. So they literally just were sent away from A&E with a Ludwig's angina. They happened to walk past the front door of the dental hospital, came in asking for help. We saw the patient, and in the history, it decided that, you know, general dental practitioner had seen the patient 9 times with pain and discomfort and swelling associated with the wisdom teeth, prescribed 8 courses of antibiotics, was walking down Oxford Road, came into that, of course we saw them, and we arranged to do the treatment, but hadn't been referred by the dentist because of the fear that it may cause nerve damage. So yes, there are risks with taking out lower third molars, but there's also risks with leaving them in, especially if patients have repeat symptoms. And, you know, this can be life-threatening for patients, facial swellings. So we need to balance the outcomes with potential altered sensation and damage to the nerve with the consequences of also leaving them in place. So in summary, it is a significant clinical problem. The mechanism behind the problems isn't fully understood. To date, there's no ideal management. There are different options to help manage, I would say, patients, not treat or cure them, but manage them. Communication, consent, and education are very important for the patient, and patient-related outcomes are important when evaluating the effect of an injury, not necessarily quantification. And lastly, you know, I hope you've enjoyed that talk. Thank you very much. I don't know if we're having questions now or later. Just the last slide here is that, you know, we are a global village, as it were, you know, and I know Shukat, well, I hope he's enjoyed himself in Manchester. I know lots of students do. Sometimes you can't attend in person in Manchester, but there is the opportunity to undertake distance learning courses with Manchester, advanced restorative dentistry and so on, at your leisure at various levels. So there is the opportunity to join the team at Manchester if you so decide. But other than that, thank you very much for giving me this opportunity to talk to you.
Thank you very much.
Hi.
Dr. Basil, our professor, you can start the questions or the discussion.
I think I have no screen here. I don't know what's the reason for this. You see me? Yeah. شيحان أنا ما عندي شاشة. ما في شاشة.
See, Prof, you need to learn some Arabic.
Okay.
Yeah.
Okay.
Just
Now I have the
and
screen again. Thank you.
we will start the discussion with our professor, Dr. Basil Brad. Dr. Basil Brad, the audience.
Professor Yates, thank you very much for your interesting presentation. Thank you for your accurate information. I have three questions for your presentation for you. The first one is I would like to ask you about the healing time after the immediate repair to gain the sensibility again partially for the patient.
Okay, so actually there are probably two aspects to that question. One is the type of patient that we actually operate on are usually the patients that have quite a lot of pain. So they have dysesthesia or intense tingling. So actually our objective for the operation is to get them out of discomfort. So once you've removed the portion of nerve and you allow them to heal, actually in the immediate post-operative recovery period over the first few days or weeks, the patients are usually very happy because they're out of pain. Then it's almost a fingers crossed time because you think, well, hopefully that dysesthesia won't return with time. Sometimes it can, but not to the level that it was. Obviously, because you've excised a bit of the nerve, the first thing you do, when you do the consent process, is you warn that any residual or any starting point of sensation they have will be removed. So they will go back to being numb. But again, hopefully, they will regain some sensation. But normally patients that are in pain don't mind that because we're getting them out of pain. Interestingly, though, usually for the first few days, patients do report that they can feel things on their tongue. But I think that's just purely because the nerve acts as a conduit for electric impulses. It's rather a bit disorganized. But normally the patients, actually, it's an overnight stay. They go home the next day with antimicrobial agents or antibiotics. And on the whole, they normally feel a lot better within the first few days to weeks after their operation. And I always review them about 4 weeks after their operation, then 3 months, 6 months, and a year, and we just monitor them throughout that period. But most of the cases, well, a significant number of them are aimed at resolving the pain, not at gaining sensation. So it's usually for those patients with dysesthesia.
Thank you. I have another questions about how long usually lasts the operation for correct or repair the injury of lingual nerve. How long? 2 hours, 3 hours usually?
It's about 2 hours. So the operation is about 2 hours. Yeah. The ID nerve is usually a bit quicker because you do most of that operation without a microscope. So you can use your loupes or your glasses. You know, it's a bit like removing a ramus graft. So a ramus graft may take 20 minutes, and then it's about carefully drilling away the bone. So that can be an hour, hour and a half. The lingual nerve, on average, it's about 2 hours. The reason being is you've got to find the central stump and the distal stump, and that can take a long time. Usually it opens up and you think, oh, there it is, done. And you think, oh, this is going to be a nice operation. Otherwise, you're thinking, you know, and you're trying to ferret around trying to find this. So about 2 hours.
Yeah, about 2 hours. The last questions, it's special questions. Which size of needle do you use usually? 7-0, 8-0?
Right, so we normally use a 9-0 ethanol. 9-0. So we use a 9-0. Depending on, now, you're meant to be able to achieve tension-free apposition. Invariably, because there's a bit of stretch in the nerve, you never get tension-free. So what you sometimes do is you might use a 6-0 vicryl, just to bring the edges together, so that you then use your non-resorbable ethanol around the rest of it. Then I remove the vicryl. The reason why we use non-resorbable sutures is that we feel that during the initial healing phase, after the apposition, we feel that the presence of inflammation can cause more harm than good. So we'd rather have a suture that causes very little inflammation, i.e. Ethelon, than something that can cause quite a lot of inflammation, i.e. Vicryl. We've done a handful, maybe 3 or 4, 5 repeat surgeries where they've had repairs elsewhere, or they've had sort of explorations, but nobody's really done a repair. What we do with those cases is, or if they've had the operation and they've come from another unit and their dysesthesia is still present, when we do the apposition, we sometimes use a collagen sleeve just to stop any connective tissue growing into the neuroma or the surgery site. That's rare though, but it's normally 9-O-ethelon.
9-0. Okay, do you prepare the continuous suture or interrupted suture?
Interrupted. I do interrupted.
Interrupted. Thank you very much. Thank you again very much. And I hope we will meet you again and again, as I said at the first.
No,
okay?
You're welcome, and it was nice to meet you all. Thank you very much.
Nice to meet you, Julian. Bye-bye. Bye-bye. Okay,
yeah, it was a very great and nice lecture, Dr. Julian. We are very happy in this presentation. I noticed that something very accurate, working under high magnification. That was very great. I have some questions of my colleagues on the Facebook. The first one is how the percentage of ID nerve trauma or lingual nerve trauma during taking the bone from the hosting place, the grafting the bone, and if we have an exclosure, what should we do? What's the ABC steps to do in these circumstances? So
let me get this right. So what's the incidence of nerve injury if you're harvesting a bone graft? Is that correct?
Yeah. When we are harvesting a bone graft, sometimes the surgeon goes deeply a little bit and take or harvest the bone, some exclosure or some trauma here or there. What's the ABC process or procedures to treat and avoid the numbing of the lip or any troubles could happen in the future?
Again, I think it's I think the overall incidence is somewhere in the region of about 5% when you're harvesting a ramus graft, something like that. And again, you'll have the same spectrum of, it may well be that you have within that, it could be quite profound altered sensation or very minor altered sensation. The way in which you prevent those is to try and keep your drilling or your sawing or your piezo surgery to monocortical cuts only. So I know I use the drill, and some people advocate the use of a piezo surgery because although it can cut the hard tissue, it's on the soft tissue. And then also when you're delivering your graft, to use the chisel and try and keep it on the lingual aspect, on the inner aspect of the cortical plate and not let it wander off into the cancellous space. And again, if you witness a transection of an ID nerve, just 2 or 3 Ethelon sutures just to act as a scaffold suture, just to bring the ends together is what you should do, okay? Because what you don't want is for the ends to sort of not align properly. I think if you get aligned ends, then that will. I've seen it a few times. I've been asked to help out with orthognathic surgery when you do the bilateral sagittal split when nerves have been stretched or torn. You know, sometimes they've not been transected, but they've been a bit stretched. And what you do is you just gently try and put maybe a scaffold suture in to help the nerve regenerate.
Yeah, the next question is, you mentioned it a little bit about the video you presented in the case. While you are repairing the ID nerve, you used rotary instruments, rotary burrs. Why don't you use the piezo surgery, even that piezo is a contra and could be benefit under magnification?
I just prefer it. Now, they were rotary instruments, but they were smooth diamond instruments. So what that means is you didn't have the coarse cutting edges of like a rose burr or a Lindemann burr. So they were fine diamond. And I just think for the access, I think you could use a piezo, but I was always been brought up. I've used rotary instruments, and I just prefer them. But the fact that it's a smooth diamond means that it doesn't interfere with the soft tissue, the same as a piezo surgery.
Another question. For example, sometimes during deep extraction. Third molar, deep one. Sometimes because of loosening the control, we make trauma to the ID nerve. We cannot get in touch to very deep in the socket. What should we do to the patient? What the ABC or the advice or the good protocol for GP or oral surgeons? Because the surgery you mentioned in the presentation, it's advised, it's an advanced type. It needs microscope, needs special tools to get inside the socket, see the nerve, and make a scaffold like this. But usually, some of traumas, even if we did CBCT, during manipulating the wisdom tooth, trying to extract it, sometimes we feel we make a trauma. What should we do in this process?
I think you're absolutely right. I mean, it's very difficult sometimes if the nerve is intimately related with the root. And I think, as I said, or I hope I sort of came over, that injury to the ID nerve, sometimes you have very little control over because it's within its sort of like bony box and you can't influence that. However, I think the important thing is that if you have disruption of the nerve or if you have bruising, I don't think it would be right to cut a big bone block out and try and do the sutures. I think it's about trying to get gentle apposition within the base of the socket. I think some people, to stop bleeding, they burnish the nerve. I think that's bad for the nerve. Some people shove Surgicel down, and again, long term, that's bad. I think it's about gentle control of hemostasis. So it could well be that you just have a damped socket, gauze, and you just compress it within the socket for 10-15 minutes. I've never had a bleed that hasn't stopped just by a damp gauze for 15 minutes. You gently take it out, make sure the nerve ends are gently aligned. If they're not, you can use a flat plastic just to sort of gently manipulate them together, leave it be. I think one of the important things to do then as well is to get good primary closure over the top, maybe with a horizontal mattress suture so you can invert the edges. Because a lot of the time when you go in and look at damaged ID nerves, it's amazing the amount of soft tissue that's grown down from the socket to the nerve. So I think if you can close it with eversion of the edges, that will prevent that.
That's really great. Another question: while we are doing an implant, sometimes we, even that we made the measure by CBCT, we feel when we do a retroalveolar, or we call it bisecting X-ray, we see that we are touching the nerve. Should we screw back the implant, or what should we do?
I think you should remove it and put a slightly shorter one in. I think that's the.
Should we do something in the socket? It's a low socket, 2 or 3 millimeters, going deep.
No, I think.
So do you prefer, for example, a corticosteroid intermediate?
Yes. So there is some evidence to say that. So first of all, if the implant is just touching the superior canal, the superior aspect of the canal, you could hazard a guess that your drill might have just encroached into the ID canal. I think as long as there's no residual encroachment of the implant into the canal, you can leave it. Right? I think as long as it's not digging into the canal, if it is, you should remove it and put a shorter one in. All right. There is evidence to suggest that immediate high-dose steroids will help with the recovery of the nerve. And I think it depends on whether you give dexamethasone or prednisolone, but it should be quite a high dose. I think prednisolone, is about 60 milligrams or 30 milligrams, and then you slowly taper it off over 5 to 7 days.
So do you prefer to add to this prescription the Norbion B1, B6, B12, for example? Repairing materials?
Vitamin B, I personally don't, but I think I'd stick to the steroid if I was going to give any medication. But again, it's all about the strength of the evidence. I think a lot of it is anecdotal evidence, but physiologically, you can and pharmacologically, you can see why they may benefit. So I don't think you're going to do any harm by giving someone some vitamin B12 if you feel that you've encroached upon the nerve.
Yeah, but sometimes what's happening? That we are facing some elderly people. There is no enough bone in the height. We try to to benefit from all the bone height to do the implant, and sometimes we have this complication. So these people are elderly people, so we reduce the medication to the lowest amount that we can, you see. So here we ask ourselves that the Nordion or B complex, it's a medication that if we are not in need to do it or to prescribe it to the patients, why do we should do that? This is the question.
Indeed. What I may do, if I might, is yeah, I mean, also you have to take into account that just because radiographically you think that something is encroaching on the nerve, it may not be. If I could just do this, if you don't mind me showing you. So I've got a case here. This case here. So you could see the implants placed here. Believe it or not, this patient had no neurosensory deficit.
Yeah, so, because the implant passes either buccally or lingually.
Yeah.
So this leads us to a question: do you believe in bypassing the nerve lingually or buccally? Sometimes I noticed webinars talking about guided surgery, so he can locate ideally where the implant should be and pass close to the nerve. Up to me, I don't prefer that, but I don't know what's your advice to the people.
My advice is for them to work it out themselves. My personal comfort zone is to use the bone above the nerve, not go down either side. But I think for sake of balance, I think if you're going to use a guide, I think it depends on the position of the nerve. If you have enough space on the lingual aspect and it's in the prosthetically correct position, maybe you could utilize it. But I definitely wouldn't trust a mucosa-borne guide. It would have to be a tooth-borne guide. Because of the variation with a mucosa-borne.
Yeah, Dr. Yats, it was really a very great topic to mention on and a very clarification method. The videos was very great. We are very happy to about your presentation. It was very great. I didn't think that one day could someone crossing the border like you come inside our university to make a lecture in such an advanced topic, a microsurgical topic. Thank you a lot. We will go to, as scheduled, to Dr. I think, Dr.
Muhammad
we have Dr. Muhammad Badr. We are greeting you from Damascus. We are thanking you for your participation. I hope you start share screening and start your lecture. The audience is yours. I'm wondering if Dr. Brad wants to say something before starting the lecture, or we can go straight
I want
forward.
to greet you. Dr. Muhammad, you are welcome with us here.
Thank you very much.
Perhaps you can speak Arabic if you want.
I do speak Arabic. I will try. أحاول. المشكلة, the problem is that when I start to switch to Arabic, I might just start to get confused, but I will try my best.
Directly.
إن شاء الله إن شاء الله.
أهلا وسهلا فيك ببلدك سوريا يا محمد.
أهلا بيك.
دكتور، نحن كثير فخورين بأنه أنتم سفراء لنا بكل مكان، فخورين بنجاحكم، فخورين بأسمائكم الكبيرة بجامعات أوروبا وجامعات أمريكا. الموضوع اللي راح تحكي فيه اليوم هو موضوع كثير يعني interesting subject. هو موضوع مهم كثير لكل طبيب أسنان، سواء كان طبيب أسنان ممارس أو جراح فم، واللي هو بيتعلق بشكل مباشر بممارسة اليومية لنا واللي هي الزراعات السنية. طبعا موضوع الطعوم العظمية أو تحضير السرير أو مهد الزرعة لاستقبال الزرعات السنية هو أمر تحدي بالنسبة لطبيب الأسنان. نتمنى أنه نسمع منك كل شيء جديد عن هذا الموضوع، سواء كان مواد سنية للطعوم العظمية أو سواء كان تكنيكال، يعني تقنيات جديدة عن الطعوم العظمية ربما تفيد زملائك هون بسوريا وبالوطن العربي، ونتعلم منك أشياء جديدة. فبتمنى أنك أنت تأخذ وقتك وتأخذ ترتاح باللقاء معنا. شو في عندك أفكار عرض لنا إياها بكل أريحية، نحن مستمعين لك، وبجوز يكون عندنا أسئلة بنهاية اللقاء، سواء كان أسئلة شخصية مني أو من زملائنا. المايك معك دكتور، و you are welcome again here in Syria.
Thank you very much, Dr. Brad, Professor Brad, Dr. Al-Jaban as well. شكرا جزيلا for your invitation for this presentation. It's quite a challenge. Let me share my screen. It's quite a challenge and change in the way we introduce our talk and lectures, especially with this COVID-19 situation and lockdown. And it's new to me to give a lecture through webinars. I usually use my hands a lot, بستخدم ايديا كتير, and I like to see my audience and interact with my audience. So it's a bit different and a bit challenging. Let me share my screen first of all.
Okay.
Share screen. Yeah. Is it shared now? Yeah. Let's see. Can you see my screen now?
Yeah, we are seeing your screen. Everything is okay. You can start, Dr. Badr.
Right. Thank you very much. So it's another challenge as well with regards to this presentation is giving it to quite a diverse audience, a mixture of dental students, a mixture of postgraduate students, and also dentists, general dentists that are interested in implants and bone grafting. So it's quite challenging to keep everybody, tuned in and interested in the talk. But I will try my best. So this talk from my discussion with Shaukat, who I thank as well for this invitation, was mainly for dental students, but also for dentists. But I can see that from the questions asked to Professor Yates, that I can see oral surgeons and maxillofacial surgeons are tuned in, asking very good questions. So I can see that we have specialists as well that are doing implants and placing implants and doing bone grafts and facing some difficulties and challenges with nerves. So that means it's quite a diverse audience. So I do apologize if you some of the lecture, part of the lecture will be basic or for mainly for undergrads and general dentists, but hopefully we'll keep everybody entertained. So me as well, I live in Sheffield, just like the Professor Yates. This is how it looks from my window this morning. But this is not every day in Sheffield or England. This is how it looked like the day before, yesterday, which is great. So we do have diverse weather as well. Today is a bit wet, so it's not too bad that I'm indoors now doing this presentation. Hopefully tomorrow will be better. So I'm going to talk very quickly about myself, just because to introduce where I come from and how I get there. So I'm from Egypt. I had my degree in Cairo University in 1996, and had my training also from Egypt at that time. This is a male Egyptian guy who had missing lower right lateral and central, and this is what they have provided him 3,000 or 4,000 years ago, which is not too bad for the time. So I wanted to have some more and diverse experience. I had my Egyptian experience. I wanted to move to the UK, went to the UK, and this is the majority of my work in Egypt, which is more trauma. But moving to the UK, I had more dental and bone graft experience. So moved to the UK, to Manchester actually. I had my PhD in Manchester, then moved to Sheffield, where I had my second training, and also finished my oral surgery training in Sheffield as a lecturer in that department in Sheffield. Loved the city, decided to live in the city, and now back in Manchester as a consultant oral surgeon, but still living in Sheffield, as I mentioned. So my PhD, which got me interested in bone grafting and bone regeneration, we have been harvesting iliac crest bone grafts to augment the top jaw, and we have been splitting our patients in two groups. It was a randomized clinical trial with half of our patients having PRP, platelet-rich plasma, growth factor enhancement for our bone grafts, and the rest had the standard bone grafting from the hip to the top jaw with no added growth factors. We did clinical and histomorphometrical analysis, and I won't bother you with all the results and the graphs, but I have some publications showing what I have seen. Just basically, it showed that platelet-rich plasma had some possible effect under the histomorphometric analysis. Not as much clinical difference we found. Mainly it was histomorphometry. أكترية الفرق كان under the microscope, the cells differentiation and bone turnover, سرعة الهيلينج تحت الميكروسكوب، لكن clinically الimplant stability والsuccess rate كانوا متساويين. Right, so why do we need to build up the bone? Obviously, because we don't have enough bone. Why do we not have enough bone? Possibly most likely due to the post-extraction remodeling, trauma as well, and I say etc. because I was, expecting diverse audience. So, as you will know, cyst removal, pathology removal, cancer therapy, we do have a long list of scenarios where you don't have enough bone. So still, why do we have to build the bone up? The most straightforward answer would be because you don't have enough bone to put an implant. This is a 3.5 diameter implant, and the bone is almost 3.5 or maybe 4 millimeter in this case. So obviously you won't be able to put an implant straight away. Implant will be not stable and it will vanish the bone. But more importantly is not enough bone for aesthetic placement. So if you do have a scenario like this, you put an implant where the bone is, and you end up with having a very long clinical crown, which is aesthetically not pleasing. Nowadays, it's unacceptable. A long time ago, patients would be happy to have a fixed tooth in their mouth. But nowadays, we have a challenge of more patient expectation and more refining of our work. This is also a similar scenario where you have a little bit more bone. You could put an implant here, but you have some compromise. So here you have limited bone to play with the angle, so the emergence would be affected. This is the central, as you can see from the incisive canal. So 3.5 implant might not be the best for the emergence profile, how it looks outside the gum. Also, if you can see here, the amount of bone that is left is very, very thin. Possibly it might resorb after you put that implant in. So you have to bear that in mind as well. So should you have that scenario and having this buccal bone resorbing, you might end up having a scenario like this, where you have this not very nice looking metal showing. And even worse if you have this kind of scenario with pocketing or with a gingival recession. As you will be all aware, you have no bone, you're likely, or you will have some gum recession. And hopefully Shaukat will give us some ideas of how to tackle this kind of specific scenario with his technique, with the new techniques of implant materials. So this is why we need to build up the bone. And do we have any predictor factors so we know which scenario will be more likely, more challenging with more bone loss? Do we have crystal ball? We do actually. We do have some ways and means of predicting how things would look like after losing a tooth. And this is the most important thing that we have to think about. And in implant dentistry, this is our first enemy, as you will be aware, the pedontium, or you can be your best friend. either عدوك الأول أو يكون صديقك الأول, pedontium. If you have a good pedontal support and ligaments and gum, you would have more favorable results. So this patient, for example, with all this recession and all this periodontal problems, you already have long clinical crown, you already have recession, you should expect possible problems with these patients. You have to be very careful. You have to think twice before you decide for an immediate implant in these cases. You have to think ahead. You have to manage, as Prof mentioned correctly, in all dentistry and in nerve repair and bone grafting, patient expectation. You have to manage the patient expectation. What else we can use to predict possible challenges or diverse outcomes is the gingival biotype. And a lot of research has been done about the gingival biotype and the gingival thickness. So they have classified, after research, thin biotype, gingival biotype, and thick biotype. And when they say thick biotype, they mean thick keratinized mucosal tissues covering the bone. How do we know if we have a favorable thick biotype patient or a less favorable thin biotype? Clinical ways, like in this scenario, you can see the bone, festooning and bone contouring is covered well by this favorable mucoperiosteal coverage, covering the roots, so you cannot see the bulge of the roots. While in this case, you can see the bulge of the root and on top of that central, the bulge of the lateral and the canine. So the gingiva is here is thin. The shape of the tooth, whether it's spindle shape or square shaped tooth, also is a good predictor. The papillae, can you see this papillae, how they look like and how thin and tapered they are? So, and also obviously the perioprobe and whether it disappears once you put in the crevice. These all gives you prediction of what this gingival biotype is. Researchers have also showed correlation between the gingival biotype and the bone biotype. So in the thick biotype cases, they have seen thicker bone envelope in those patients. So again, you should be managing patients' expectation, and you should be be prepared once you have a tooth out in a more risky patient. So in the UK, most of our patients are referred patients to us, either referred to our practice or we go to other practices to mentor implantologists or to place implants. So in some scenarios, in a lot of scenarios, they do the extractions themselves, but I'm not sure about Syria. Possibly you do the case from A to Z in majority of cases, but in here, we sometimes take over the care of a patient. So what I would suggest, if you can, is to take the tooth out yourself, measure or feel by the perioprobe whether you have a buccal bone or not. If you do have this scenario, you should be doing something if you were planning to put implants in the future. We know from research that 2 millimeter is a safe bone thickness that is possibly gonna stay. However, we have this study, for example, and this particular study showed that almost 70% of their patients had the buccal bone thickness of a millimeter or less, mainly in the central area. And this is very big number, 70% of patients. Also, they also showed that this critical number 1 millimeter, it's very critical. Above 1 millimeter, it's more favorable. Less than a millimeter or even 1 millimeter, you have a significant risk of losing that piece of bone. So you should think of preserving that bone or for regenerating that bone, maybe with a GBR, as we will be mentioning later on. Try to do it yourself, do the extraction yourself, try to think ahead and make yourself a favor by preserving that bone. Tooth is out, you need to put something in place. So also think smart and do something that will not compromise the buccal aspect. I'm sorry, I don't know what the buccal in Arabic. Sinhi يمكن, Sinhi, maybe it's the vestibule, I'm so sorry. But the buccal aspect needs to be preserved don't put a big flange that will impede the healing and cause collapse of that buccal bone. This Essex, I like this a lot. I use this Essex retainer. We put a fake tooth in place, like a composite or any white filling material in there, and the patient wears this. They like it a lot. They just snaps on. You can't see the rest of this Essex retainer. It has no flanges and it's really quick and good and tissue friendly. This is very good as well. It relies on the palatal side and not on the buccal side. So as you would imagine, I won't spend too much time on this as well. Bone grafting, not for everybody, or at least you have to prepare the patient for it. So in patients with complex medical history, as Dr. Was it Dr. Barad who said that we deal with elderly patients more and more now, and with complex medical history, medications, and we have to bear that in mind. Patients with bisphosphonates or radiation, both of these drugs or treatment modalities causes less blood in the area, as we will see later, and also too much blood can kill. So you have to be mindful of this as well. Smoking is another enemy to the tissues and to the bone grafts and implant survival and success rate. Now in the lockdown, I had a lot of time in my hands. I spent a lot of time in my garden, as Prof would know. I did a lot of trees, taking trees from one place in the garden, put it in another place, and it hit me that the resemblance between transplanting a plant or tree and transplanting a bone graft. The principles are strikingly similar. So I'll show you a slide with some pictures and try to draw what the principle I mean by this picture. So I will pause for a few seconds, have a look at the picture, and see what do you think this means if you translate this to bone grafting and bone augmentation principles. Okay, so I will talk a little bit more about these three in a minute, but as you can see, here we need some fixation. You put a transplanted piece of stock, you have to cover it. So this is the coverage and the fixation and stability of your bone graft or plant graft during the healing. You have to expose the area. So when you put a block graft, try to either take the cortex out or fenestrate the cortex. So you can have cortex to cortex, cancellous to cancellous rather than cortex to cortex, to allow for the integration of the graft. You need to leave it, to give it time to heal. You need blood, obviously, and you need a scaffold. I know that in Syria, you do a lot of grape. تزرعوا عنب كتير في سوريا ما شاء الله, كرمة العنب والscaffolds around it, and how this particular plant needs this scaffold to grow on top of it. Sterilization, your surgical skills, and the time that needs for this all to work. These are the biological aspects of the bone healing, and this is the code inside the bone, as it is the code inside this plant of what to do in what situation. This is the code of how the bone would react and heal in every situation. Also blood supply, and not only blood supply, new blood supply, angiogenesis. We need new roots to grow from this plant to mend and entangle with the soil. We also need this bone block to have some tags of blood coming from the bed. So osteogenesis, very quickly, basic again, it's the ability of the survived osteoblasts to lay bone straight away. So when you have a fractured bone or you have a transplanted bone, you have some osteoblasts. These survive the transplant process. They gain blood supply from elsewhere, and they lay down bone straight away. This is minimal, obviously. Osteoconduction is the ability of the bone to use what is the setup around it to climb and lay down new bone. So just like the blood clot is the scaffold, but also in bigger defects, you need something else to give that scaffold for the osteoblasts to migrate and put some bone there. Osteoinductive, and this is where the stem cells are convinced by the osteoinductive materials in the vicinity of the defect to differentiate into bone-forming cells. Obviously, these three are present only in the autogenous bone grafts. This is mainly in the other types of bone grafts, but those two or those three are all present in the bone and the autogenous, which is the gold standard. Blood supply, compromised blood supply, we have to be careful with that. Irradiated patients, this is relative contraindication. Patients on anti-resorptive medication like bisphosphonate, this affects the blood vasculature in the area. Patient with actually anti-angiogenic medications, like in cancer. So the whole idea of this medication is to prevent new blood vessels. So this is an important factor to look at. We would all like to have a patient with no medication, but in fact we have patients that comes with a long list of medications. We have to go through that list and act accordingly. Also, we have to be very gentle with flap handling, and that's to preserve the source of the blood supply. This is a ridge split case that we have done, and it's just those pictures just to show you the flap. Try to put the flap incision line in a keratinized mucosa. Try to not to put the incision line over the graft. Suturing also, this particular flap used the Vilvart or the papillary base incision to avoid recession. So the Vilvart technique, you can go back to it. It's a very good technique to try to minimize recession. You have to also think about the suturing material that you will be using. In this case, you use a non-resorbable ethylene suture, proline suture, 6-0 proline in this area. While this is not as critical, you can use whatever you want. If you have time to put non-resorbable and you have time to see the patient take them off, that might be better. But as I mentioned, if I go to travel somewhere to put some implants, it might be more easier or convenient for the patient to have some resorbable sutures, as in this case. Right, so we'll go now for the guided bone regeneration and bone grafting and the concepts and principles around these. So this concept of bone or tissue regeneration introduced in 1976 or so by Melcher. Mainly it was used in the beginning for pocket eradication. The main concept, whether it's pocket eradication or bone regeneration or even nerve regeneration, because Prof have touched upon this when he mentioned the collagen cylinder to keep other tissues away. This is the concept of tissue regeneration, whether it's pocket or nerve or bone. So it's mainly to keep away non-osteogenic, in this case, in bone grafting, to keep away non-osteogenic cells. So we know that we have connective tissue cells, fibroblasts, and epithelial cells. They are very good in multiplying, getting in the way, and healing. And the body, it doesn't care. So in this case, can you see how it dipped down? The body thinks it's a great result. It's asymptomatic to the patient, to me, as a body. I'm functioning well. There's no sharp edges. There is no pain. There is no problem. But this is a big problem for us when we want to put an implant here. So we need to use the built-in ability of the bone to regenerate, but direct it and guide it. So we need to keep a 3D space, keeping that gum away, not to drop in the space. And depending on the size of the defect, you could just leave it and blood clot will form, and that's it. Or you most likely, and in majority of cases, you might need a bone graft as well. So guided bone regeneration can be, most likely will need some sort of bone graft at the same time. So this is the concept of guided bone regeneration. Most likely you will be needing a type of a barrier membrane, this barrier membrane can be soft, can be rigid, can be resolvable, absorbable, or can be non-absorbable, and you will have all those pros and cons of each one. You will know that, these are the most used ones. These are, as you will tell, can keep their shape. So you can make like a tent underneath. You can have some bone building and regenerating underneath, and for more forward like vertical defects. But they have their own problems. They have a problem of the dehiscence, bone mucopreosteal breakdown, infection. Because imagine you need to put this in, and you will leave it for 6 months, 4 months. So this is a risk. Another biological membrane is the PRF. As I said in my PhD, I used PRP. This is like a sister product. I will be very careful when I use, I would say when you have your expectations, so don't expect miracles, use them. They are quite good. This platelet-rich fibrin membrane, you can use them. You can have the machine in your practice. You can use them for your patients. So they are biocompatible. They are from the own patient. There's no rejection, no problem with that. But you have to manage your expectation and the patient's expectation, not to expect miracles. So this is the guided bone regeneration. So in these scenarios, we will just go quickly through those scenarios. JBR will have their limitations. You have to think about the size of the defect. How many walls do you have? Where is the blood coming from? And this case, I raised a flap, found these holes. Before raising the flap, I took the tooth out, filled with the perio probe. You feel that holes in there, so you raise the flap. It's not too bad actually, as you would tell. So you just put a membrane here to prevent the mucopreosteum from sending connective tissue tags through those holes and compromising your healing. So maybe just a membrane should do with this case. In this case, that was a kind of an unpleasant surprise. Obviously, if you do CBCT, you will know, but this patient came young, lost the central, I felt the buccopalatal area, and it was very nice, healthy, thick, as I felt it. So in my cases that I've done in the hospitals, the University of Manchester and Sheffield, I did, as you all do, raise the flap and, oh, that is not that much bone there compared to what you felt. But normally you'll be, as if you feel it very, very good, healthy thickness, you'll still be able to put an implant there and put some GBR and some bone graft. But in this case, it was that big defects. I could not put an implant there. That was not was I expecting. I was expecting some compromise, but not that much. So a lesson to learn. But you have some tools, ways, and means to bail you out. So safe scraper, a lot of bone scraping from the area. Mix it with some bios or bovine bone chips and a membrane, and this should be fine. However, this is a much bigger defect, obviously, and hopefully you would agree with me that it needs a lot more work and a lot more planning. As you can see from research, they believe that only 4 millimeter you can gain if you are not using autogenous bone grafts. If you're just using GBR, some bone chips from here or there, you might not be gaining much. However, you need proper autogenous bone grafting, maybe blocks, to tackle this situation. So this is some examples. This is a similar example, but not as dramatic in terms of the size of the hole. However, as you can see, it is still thin. So you can fill this with chips or even leave it with a membrane. It will fill with bone, but the bone thickness is thin. So we need the membrane here. If we build this up with a pile of bone graft with a resorbable membrane, there is a risk of it collapsing, but it could still be okay. But in this case, just to play safe, I have placed a PTFE titanium reinforced membrane, left it for 6 months, opened, nicely healed. You can still see the bovine bone chips here and there, which what you expect. You won't expect those bovine chips to disappear quickly. Implant safely placed. This is another scenario where the PRF membrane is being put to isolate this grafting inside the sinus. So as I mentioned, most likely you will still be needing some sort of bone grafting, and we need to borrow some bone from somewhere else. You can borrow from yourself or from the patient's own bone, autogenous. You can have from cadaver, from a fellow human, or from an animal or synthetic material. Bone grafting is the gold standard. Autogenous bone grafting is the gold standard. They have all the good stuff: osteoconductive, inductive, and osteogenic. Biocompatible, no problem with rejection, disease transmission, no problem with that. What you would expect, as you would expect, what comes with it: morbidity, extensive surgery. Patient might not be happy to have a second site surgery. All these drawbacks in this modality. About the types and where to take bone from, you can take from the iliac crest, from outside or inside. You can take from chin, ramus. These are the most common places you take bone from inside the mouth. This is what I like. I have done this, but I think that ramus grafting is the one that I prefer myself. You can have it block grafts or particulate grafts. They all have their place. Allografts are becoming very, very popular now. I have used them. They are impressive. You have to again master the basic principles and techniques. But I think it's becoming a competitive alternative option. They are mainly osteoconductive, like the freeze-dried bone. But if you process it with demineralization, they expose the bone morphogenic proteins, and they possibly research needs to consolidate more and prove that. But it's suggested it's more osteoinductive. It comes in both blocks or particles. It's readily available. The problem I can feel here, at least in the UK, it's quite expensive. It is quite expensive. So some patients would just say, well, why not to take in a piece of my bone? So, but as it becomes more, more companies offering them, we might have them in a more affordable price. So this is the allograft. And as you know, the bone from animals, bovine bone or alloplastic, these are the most widely used, less expensive, readily available. This takes a long time to integrate with the area. They don't resorb that quick. And this, on the other hand, it resorbs and replaces by bone much quicker, but they don't keep the shape. So there's like pros and cons to anything. This keeps the shape quite well, but it doesn't dissolve or integrate. They are both. You have to choose the patient and the case, because the bigger the defect, the more difficult for the blood to come from everywhere to fill this dead particles of xenograft or alloplastic. So you should be confused by this point in time with regards to what to use and where and when to use what, which is absolutely normal. we have some scenarios. We can think together. What is the best way forward in each scenario? So this is a sinus lift and bone graft. If you remember with me the plant and the principles we mentioned, what is in there and what is not. So osteogenicity, do we have osteogenicity here? We do. Do we have a secluded area with no micromobility? Yes, we do. Very nicely secluded area with not a lot of mobility. Blood supply, very abundant blood supply from everywhere. So we have the majority of the principles we talked about is present in this scenario. So it doesn't really matter what you put in the sinus. You can even just leave it with a blood clot. It will form into bone. You can put alloplast. You can put a mixture, which what I prefer now is to put 50% chips for bone, autogenous bone scrapings, and 50% of xenograft. You can just literally put a lot of things here, and it should work. What you need to be aware of in these scenarios, as you would, a lot of you would be, is the osteogenicity of the sinus. So in this case, if you keep going in the picture that way, it's becoming thinner and thinner, and the osteogenic potential in this area is quite poor. Blood supply is quite poor in this end. So you have to be realistic. I have seen a lot of colleagues, dentist colleagues, referring patients to me with a very pneumatized sinus and asking for a sinus lifting. You could do the sinus lifting, but most likely it will not work if you don't have the blood supply and the osteogenicity that you need. In this end is not too bad at all. It's very good. You can do this sinus lifting over there, and you can have a good bone amount of bone for a few implants. You can put 2 implants there and maybe a small posterior cantilever. It depends on what is the opposing. You can have a 3-unit bridge or so. You can benefit the patient a lot without having to do heroic surgeries. So this is the lateral approach and the sinus lifting. There are modern and more, newer techniques. We will be mentioning these quickly at the end. Be aware of the septa as well. As we mentioned this, we mentioned also a patient with sinus problems. Obviously, you have patient with a polyp in there, sinus problems. You have to be careful of, and selective of your patients. This scenario, I'm sorry that the picture did not show the rest of the ridge, but believe me, it is thin. These teeth were taken out. These also are meant to be taken out, but we are keeping those for now for prosthetic purposes as a temporary prosthesis for the patient. Bad loose teeth or compromised teeth were taken out. Very thin ridge. We need a block to fill that thin ridge. These are allografts placed and fixed. Remember the principles. We need this not to be wobbly moving while healing. This is prior to putting bone chips in these gaps. Don't leave those gaps. You need to put bone chips in those gaps. You need to get these rounded edges. Don't leave those sharp edges. Otherwise, it will compromise the mucopreosteal coverage. It will break down. The wound will break down, and you have those exposed. And if you have an exposed block of bone, it is a very poor prognosis. So this is after healing. This is 7 months after healing. Very nice integration. If you push that mucopreosteum down even more, you will see this also nicely healed. Screws out, teeth out. They were there. Implants in, and Olum 4 placed. So this is allograft. You leave it for 6-7 months, while autogenous bone grafts you leave for 3 to 4 months. So this is iliac crest bone grafts. This is iliac crest bone graft. I think this was ramus graft, and this was also a ramus graft. Fill up the gaps, smooth the edges, and I didn't mention the mucoperiosteum. You have to release the mucoperiosteum quite well to have a tension-free closure. This is very important, tension-free closure. So we leave it for 3 to 4 months. The autogenous bone grafts, nicely healed. And here as well, nicely healed bone block, implants placed, happy days. This is the ridge split that I showed you earlier. You have to think about the cancellous component. If you have a very thin ridge with cortex to cortex, don't try ridge split. Try to do CT scan, see if you have cancellous bone. If you do, especially in the maxilla, it's easier, flexible, and in younger patients as well. Try to make your cuts. I use piezo for this case. So piezo cuts, and then you put the chisel inside the gap. You make a little twist so it starts to lean, and then you start to put your implant, which itself will push the buccal, this split bone out. You fill in the gaps with whatever you want. In this case, it's just a ridge split, so you can put xenografts, you can put some bone particles in harvests from elsewhere, a membrane, and a tension-free closure. Complications, you should know that complications will happen. I've learned that you could say the hard way. Various kinds of complications can happen. I did not mention the nerve damage complication that you have mentioned in your questions, which hopefully avoidable, but it is very important to be mindful of in those patients, especially if you are harvesting ramus graft. Know where the nerve is. Stick to the protocol as Professor Yates mentioned. Cut the cortex and don't go deep into the cancellous, and then you're safe that way. Dehiscence and bone blocks, bone breakdown is also a challenge. There's not much you can do if you have done everything right in terms of the place of the incision line and the suture and the release, but to give it a good clean. Maybe it will granulate, or maybe if it happens early, you can debride this area. You can take the piece of bone out if it's taken out and put a couple of stitches. You can also try that. Bone dehiscence or bone you open up and you have the buccal bone just flying off. It happens quite often. The more you do implant placements and grafting, you could possibly expect or predict if it's going to happen. So if it does, you should have something in place to bail you out. حاجات تطلعك من أزمة، خليك جاهز، عندك حاجات alternative options زي bone scrapers and a number of other bone substitutes. This is also a possible complication with the nice autogenous bone grafts that we have shown you. It can also go south by resorption. So this is a resorbed graft, not all of it, but some of it has resorbed. If you do have enough crystal bone, you're okay. You can put the implant in and you can augment this area, or what we call, sometimes we call elective GBR, which means you put the implant in, you have a thin bone buccally, and then in that case, you put some bone chips from the ocean patients on bone scrapings, or bovine, or both. You can just collect some bone from elsewhere, but put some, I would almost always put some bovine chips on top, and that is called elective. Why is it called elective? Because you don't have a fenestration like this. You just have a thin bone. You can just see that it is very thin. Then you can put this augmentation material to aid this bone thickness. This is a Remus graft that I have done, and you will not imagine what problem I had in this case, and I'll be honest with you. The bone graft went quite well, and we have done a Khoury technique. Professor Fouad Khoury, you can go back to his publications. He uses 3D box scenario to build bone up vertically and horizontally. So just make a bone box inside which you put whatever you want. And the problem I faced in this case that we ran out of suitable size screws. So we didn't leave that one that way. We did place a screw in there, but I would have been much happier if I had longer fixation screws. I had to manipulate the angle of the screw for it to give me the stability of the bone block. Don't do like this mistake like myself, and be prepared to have a lot more than what you need in hand. Right, so as times goes by, we are doing less and less of what I have all mentioned. We are doing less and less of that, to be honest. We are doing a lot of it, but I expect we do less and less as time goes by. And that's because of what the aging population that we have, as you kindly mentioned, and their medical history. They are not, ready to have a big surgery. Their high expectations as well. You need the surgery and the implant and the graft, and you need it now, just like children, the kids. I want it and I want it now. Also, we have recent techniques, pterygoids, zygomatics, all on fours. We have designs, novel designs, like the coaxial implants, where the implants are in one direction and the opening is in another direction. Multi-unit abutments, angled abutments, and short implants. We have ways and means of going around deficiency of bone. We also have novel instrumentation like bone expanders, and we have the bone densification technique, which is quite hot topic now. I wish I knew that we have a lot of oral surgeons in the audience, more than what I expected. I was expecting more like undergrad cohort, but mashallah, a lot of surgeons. So I would have possibly added more specific and sophisticated, new techniques in place. But I know that you will be with me in those new trends and technologies. The VersaBear is a new technique. We just purchased in the clinic a new kit of this. I love it. It will allow you to, within limits of obviously, to minimize your open sinus grafting. You will be able to put, if you go up maybe 4 to 5 millimeter, maybe even 6, you can gain this with VersaBear. But more than that, you have to have an open sinus lifting. So what do I need to say in near the end? I would like you to expect, to know what to expect, not to expect miracles. Manage your expectations and your patient's expectations. Work within your competency, work on your skills, develop your skills more with time. Soft tissue handling. Soft tissue handling is very, very important, is paramount in these scenarios. Respect the tissues. The tissues will respect you. Don't rely on technology only. As mentioned earlier, we have a lot of tempting technology, 3D stents and 3D printing. So nowadays, the company rep will come to you and say, I will give you a bone block that is printed to the defect that you have, and I will give you a stent that you will put, and then you can blindly just close your eyes and drill through. Don't rely on this. This is potentially dangerous. Be prepared with the plan B, just like the scenarios mentioned earlier. Have plenty of things to bail you out, and select your case carefully. And treatment planning is everything. I would like to end up with this case, which represents this case selection importance. This is a gentleman in his late 40s. He's a pilot. He had a bike accident. He chipped his lateral and his central is broken. The root is inside. He came, he wanted an implant. And obviously he is a high, you could say he is a high demanding patient. It's an aesthetic zone. He is a presentable gentleman. He works as a pilot. Money is not an issue. Time could be an issue, pushing towards more like an immediate implant. So managing the patient is very, very important here. He was very, very helpful. We came to somewhere in between, not to put an immediate implant, but not to wait for 2 months or 3 months. So we have allowed the gum to heal. We have placed a temporary removable partial denture, the one that I showed you earlier, that will keep the nice papilla up, otherwise they will collapse. So the papilla was pushed to the sides to keep that nice shape. This has healed well. So when you open a flap and then you put your implant, that what we call the jump gap, you will have a gap here because it's not healed yet. This can be filled with autogenous or mix of autogenous and bovine bone, and then you will have this nice gum to stitch back. So you don't have an open bone graft. If it was immediate, obviously you will imagine what I'm saying. You will have that bone graft leaching out and spilling out possibly. So this is like a delayed placement. This is after placement and exposure, nicely healed cuff. This is how he looked after the composite repair and the tooth replacement. Patient had to go to the lab. So also we are very lucky. We have good labs here in the UK. This particular lab I used was mimicking the patient's colors. So the patient had a very nice emergence profile and matching. It's very, very difficult to match central, as you would imagine in your practice, but with having a good lab, you can try your best. So in this case, a number of things coalesced together to give this good result. The last one was the surgeon and the surgeon's skill, my skill as an implantologist. But the patient's oral hygiene, the patient's keratinized tissue, the gingival biotype, the choice of delaying the implant placement rather than putting an immediate, the choice of sending the patient to the lab, all these came together to give a good result in this scenario. At the end of the talk, I would like to thank you all for inviting me for this lecture today. I hope that you have been entertained. I'm sorry if it was repetitive in some parts of the lecture, especially for those experienced implantologists. This is surely the first, but not the last. And we will be, we'll be happy to have some questions if we are ready for that.
اوكي دكتور انس، معي انت؟
يا دكتور باسل.
ايوه معك انا.
Thank you, Dr. Mohammed Badr, for such a great lecture. I think maybe Dr. Bassel Brad has any questions, or can I start asking the questions from my colleagues?
Surely. Dr. Mohammed, I thank you very much for your interesting presentation. Surely I have one important question for me. The big challenge was the bone grafting in the mandible alveolar. Do you have any idea, any materials? Do you have any techniques that can we use to have a good result for bone grafting in the mandible? For the maxilla, it's no matter, but for the mandible is a big challenge. Would you have give us your idea about this?
Right.
So زي ما Dr. Basil, Professor Dr. Basil, you mentioned, the mandible is a bit of a challenge, and the reason for that challenge is the nature of the bone in the mandible being very, cortical. So the blood supply also to the mandible is not as abundant as in the maxilla. Do you have a specific scenario? Is it like a front area or the back area? Do you have a specific scenario? في حال يعني حالة معينة الماندبل عموما ولا في حتة معينة؟
mandible in common.
Yeah. In my experience, the main thing I think helped in bone grafts in the mandible is to do the fenestrations in the cortex as much as you can.
Okay.
So some of my colleagues take the cortex all out, but I would say if you do the fenestration in the buccal cortex, this is very important. It's not that important in the maxilla, so you might do it. You might just put the bone block on the surface. Sometimes we do that as well, but in the mandible you have to put a lot of.
This is what I want. Well, I wanted to hear from you: the fenestration, and
Yes.
To drill the mandible to have enough blood for the bone graft.
Absolutely, yeah.
Okay, I have no other questions. Perhaps you, Dr. Anas, you have another question.
Yeah, Dr. Brad. The first question to Dr. Badr, after we thanking you for the lecture, the specific lecture about grafting and bone augmentation. The first question is, why should we cover the area? Should we cover the area with a membrane when we are doing Khoury technique, buccal plate or buccal shield plate? So should we do a membrane or not?
In theory, no. In theory, it's a bone block, autogenous bone block that you are using. But however, in the Khoury technique, as you will know, he takes the buccal, the cortex, and he splits the cortex, and he is using those lamina to make the box,
to make a home for the bone. Yeah.
Yes. In my own opinion, I think that it might be safer to put a membrane, and that's because it's not as the bone block that I showed you in the coming from the ramus.
Sometimes the roof of Khoury technique, most of cases they don't do any plate. They just do the plates buccally and lingually, and the roof or the top is with nothing. There's just suture. Do you prefer to go with a membrane?
Yes, I do. I do prefer to put a membrane on top, and that's to minimize the dip in the mucoperiostrum that might happen, to minimize the possibility of unfavorable cells going on and getting into the healing bone graft. So I think I would prefer to put a membrane in general. Yeah.
Yeah. When you mentioned about the place where we put the bone grafting, we make in the mandible some fenestration. I agree with Dr. Brad and you about that, but we see some webinars, especially when they use xenograft, they put it without fenestration.
So so xenografts in the mandible, or without fenestration?
The mandible, no, in the mandible. And allograft sometimes they use it in the mandible with no fenestration. And
do they use it like an elective GBR? Like, for example, there is no missing bone, but then
there's just thickening the buccal plate.
Yeah,
like when we do an implant.
Yes, because this is it's not, it will never be bone. So this technique, it's fine, but it will never be bone. It will be like a thickening of the buccal.
Yeah, preserving area to stop any bone resorption in the future. It's not an infrastructure bone that we will implant in.
Exactly.
So the next question, when we have a socket with some fenestration in the buccal wall, should we raise a flap? Why don't we communicate or deal with the situation like we have three wall deficiency and put the bone and pack it inside and suture over, because we will keep the blood supply from the buccal periostome. So is it obligatory to raise a flap in this situation?
So in that case that I showed you with the small fenestrations. These small fenestrations I have seen in another patient where soft tissue tags has been sent from the buccal.
Entrapped and grown inside.
Yes, and pulling the buccal mucoperiosteum inside. But that in that case, nothing was put in the socket. But as you mentioned, if you are putting
some material, wrapper or xenograft or allograft or whatever.
Yes, if you are putting something like socket preservation and the majority of the buccal plate is intact, yes, you can leave it without, because you will be minimizing the disruption of the blood supply to the buccal plate by not raising a buccal flap.
Yeah. Thank you a lot, Dr. Mohammed Badr. Thank you for this crossing border meeting, crossing borders lecture. It was a great honor of us to have you here. We hope in the future that you physically visit us and give a lecture in our auditorium. Thank you. And thanks for Dr. Ashiti. We think it's your role. Now, Dr. Ashiti, it's your time. Our special ambassador, really. We're thanking you a lot. You can start your lecture on site, and I hope maybe Dr. Brad could say something before the lecture, if you prefer, Dr. Brad.
اهلا وسهلا بحضرتك دكتور شوكت. يمكن هذا اول لقاء لنا وانا كثير مبسوط بهاللقاء، وان شاء الله بتكون بدايه تاسيس علاقه جيده ما بينكم، ما بين حضرتك وبين جامعه دمشق كليه طب الاسنان، وما بين الجامعه وما بين جامعتكم مانشستر هنيك. I would like to welcome you. You will have 45 minutes. You will speak about the comparison between the zirconium and titanium as a materials in dentistry, especially in manufactured dental implants.
Yes.
Yes. الصراحة أنا بدي أحكي لك شغلة. أنا كنت متمني دائما وعلى مدى 20 سنة الماضية إنه تصير الزراعات كلها زركونيوم. من كثر نحن ما عانينا من التيتان ومن الانكشافات العنقية للزرعات والنواحي التجميلية. صراحة كنا نتمنى لو كانت هي الزرعات لونها أبيض، لو كانت هي الزرعات لونها شكل تجميلي أكثر، يمكن كان حل نهائي لكل مشاكلنا. هالشيء هذا يمكن أنت تعرض لنا إياه هلا.
هلا المحاضرة تبعي هي عن مقارنة بحتة ما بين التيتانيوم والزركونيا، مو الزركونيوم.
نعم.
وهي مثل ما نقول pre-clinical evaluation and comparison between the two.
Yes.
فأنا ما راح أرجي حالة ل implant ببيشنت فأقول مثلا كانت السيرفايكال مارجن هون good وهون good. لا، نحن راح نقارن ما بين الستاديز
as materials
in
pure materials,
labs or preclinical maybe on animals.
Yes.
Also we would have a bit of brief in clinical studies, because until today we don't have that much of human studies.
Okay.
So it's a bit more basic and compare.
Okay, we are with you. The mic with you now, Dr. Anas.
Dr. Ashiti, thank you a lot for your participation. It's a great honor that we can get your presentation now. You can make share screening. We made the approval on the hosting computer. We are very happy that you are meeting us again in the second Damascus Manchester meeting. You can start. The people are yours and all students are listening now. I'm mentioning that we have close to 7,000 people watching us on the Facebook, Dr. Ashiti. That sounded great.
No pressure.
A lot of people watching us and following the lecture, something new, something advanced, something benefit. You can start the presentation. Thank you, Dr. Shulkan.
Okay, so first of all, thank you everyone. Thank you for your welcoming hosting and for appreciating my efforts here, despite that I didn't do anything. So for the lecture, we are going to talk about zirconia versus titanium. So we're going to compare between the studies that we already have about titanium and the recent and current studies of the titanium, of the zirconia. Okay, so first we're going to start with this. It's a bit clear clarification of zirconium and zirconia. As Dr. Bassel said, zirconium. So we have here in the element tables we have titanium and zirconium, which are in the same group. So if we give titanium and zirconium together, we get titanium zirconium, which is a rock solid metal, and it has a metallic bond, and it has free electrical electrons that could have a high electrical conductivity. However, if we have zirconium and oxygen, we will have zirconia, and this is our material. So zirconia is a zirconium dioxide, whereas the oxygen is mainly structuring the crystal of this material. We have ionic bond. We don't have a metallic bond. And this means there is no free electrical, so there's no conductivity. So as a bottom line, zirconium is not zirconia, and we are using zirconia. However, there are titan zirconium implants, but we're not talking about these things. We're talking about zirconia. So what really matters for us as dentists or oral surgeon or whoever is interested in implants, we are looking for mainly osseointegration. So we want to know if we put this implant, we're going to have healing, and we want peri-implantitis because it's like the crystal of this material, because it's a main factor in failure of the implants. We want to discuss the biomechanical features and also the survival and success rate of zirconia as an implant material. So we'll start with the osseointegration. Now, mainly, it's always been discussed the treatment of the surface of the implants. So the micro surface of the implant, we say that the microsurface can make biomechanical retention for the implant, and also the nanometer treatment of the surface can make the initial protein interlocking for healing. So if we look here, we have the titanium SLA, which is titanium sandblasted and acid etched, and also we have the zirconia to the right, surface treated, also in the same way of titanium, sandblasted and acid etched. And this ZLA and SLA is like Stroman way or brand name for this treatment. So in the beginning, we can see that there are similarities in the topography of the two surfaces. Okay, now let's start with the studies. A study on 15 pigs found that, like, after putting the implants and take them after 8 weeks and 12 weeks, we can see that the bone implant contact, which is a factor to evaluate the osseointegration, was similar between both. So if we see that is the bone and this is the implants, we can see that there is a bit here deficiency. However, in the titanium, there was not. Okay, so the study found that there is no statistical difference between both implants. Again, if we want to, in another study, which was on dogs, they found that the removal torque, which is another factor to evaluate the osseointegration, was also similar in both implants, titanium and zirconia. However, there was an incidental finding that there was a bit of exposure of the threads of the titanium implants that was not there on the zirconia. But that could not be published then because that was not the main aim or objectives for the study. Another study, also the similar thing, and it was in animals. Again, there was no difference in osseointegration between zirconia and titanium regarding bone density or bone implant contact ratio. So, bottom line, in osseointegration, 3 systematic reviews and meta-analysis looked at the bone implant contact and the removable torque value, found that no significant difference between zirconia and titanium implants. Also, both implants illustrate similar bone and soft tissue integration. The study samples, it was being a bit differences between the outcomes if the samples were dogs or pigs or even sheep. So study sample had an impact. Also the surface modification as the more increasing the roughness of the zirconia surfaces, the outcomes of the zirconia was different, which can tell us that there are still not valid or a fixed type of surface or modification for the zirconia to have the best outcome. So finally, modified zirconia implants, which would be acid etched and sandblasted, can be potentially a successful implant material. Now, the second factor is the peri-implantitis. Similarly, we are going to use a bit of previous studies on abutments. So the zirconia abutments only, because which is something we already use. Yeah. So we have in vivo study, which is on patients, 5 patients, comparing between the rate of inflammation between zirconia and titanium regarding only as a healing cap, and it was higher in the titanium group. Again, 6 patients also, comparing between the bacterial count on 3 different discs, and it's found that the commercial pure titanium had the highest count of bacteria, while the zirconia abutments was the lowest. Another one, comparing between smooth surfaces discs, resin, zirconia, and titanium. Those ones were not in patients, were just like in the lab. They were incubated with the Streptococcus sangus, and it has been found that the resin was high susceptibility for the Streptococcus, while there was no significant difference between bacteria adhesion between zirconia and titanium. Now, they brought titanium and zirconia discs. Both are either smooth, as we can see here. This is titanium smooth, and this is titanium modified, and also zirconia smooth and zirconia modified. And it has been, with the 3 species of bacteria, been incubated for 72 hours. The results were that it managed to be in the titanium, there was a bit of homogeneous structured layer of bacteria. So the titanium had more structured formation of bacteria on the surface. So the results were this. Finally, we can say the study on dogs radiographically evaluating the bone loss after ligature. This is another study which was in dogs, and this is inducing bacteria by using ligature-induced peri-implantitis, which is kind of a knot that we will put it around the implant and would induce the peri-implantitis. So 40 implants have been placed and restored after 6 weeks, 20 titanium and 20 zirconia. After 4 weeks of functional loading, the oral hygiene procedures stopped, so there is no cleaning. And this is when they put the ligature-induced knots. Now, after 8 weeks, we removed this ligature knot, and the plaque or bacteria has left to grow. X-rays was taken, and we can see this is the beginning of the study. Everything was fine. And this is at the end of the progression. This is when the ligature been removed. And this is 2 weeks after ligature removed, and this is in the end. We can see that this is the titanium and this is the zirconia. Here we can see around it, there's like peri-implantitis infection. And here it was less. This is the X-ray. This is at the beginning. We can see more resorption around the titanium implants, which was less in the zirconia. Bottom line, so all implants were successfully osseointegrated at the beginning. So no implant had a problem at the beginning. After 2 weeks, 1 titanium implant fell out. Also, X-rays demonstrated that zirconia implant was statistically significant reduction in bone loss. And the study concluded that zirconia was associated with less inflammation compared to titanium. Now, biochemical fatigue. So when we are studying the biochemical fatigue, we are studying 2 factors, despite that there are many factors, but they studied those 2 factors on zirconia. Fracture resistance, because it's always doubted if zirconia can handle the same functional loads of zirconia, of titanium, and aging. Aging will come in a bit now. So in the beginning, the fracture resistance, they use different functional loading and put these implants under different periods. And the study found that the modified zirconia monotype implants, which was the one-piece implants, has a highest fatigue resistance compared to the two pieces implants. And also the modification of the surface of the zirconia has an impact there, as the sandblasted acid etched was stronger than the sandblasted only. Aging. So the zirconia is at room temperature, has 3 different phases: monoclinic, tetragonal, and cubic. In dentistry, we use the tetragonal. Why? Tetragonal has a feature of resisting micro cracking, and every ceramic material has something called micro cracking. So with addition of a material called ITRA, the tetragonal phase was stabilized. Now, after more discovery, they found that this tetragonal phase can, with at low temperature and watery or wet medium, can start transferring to monoclinic and go into something called low temperature degradation. This low temperature degradation can cause roughness of the surface, which can affect the osseointegration of the implant. So that was called aging, and that was like causing a lot of problems in the beginning of using zirconia in hip replacement, and they stopped using it. So a lot of studies has become to check this aging on ceramics. So a study used accelerating ages. So they will put the implant in a medium, and this medium would make the implant, even if it's few hours, would look that 30 years or 60 years has been passed in vivo. And they found that the aging has a minimal effect on zirconia. So a systematic review and meta-analysis concluded on both fracture resistance and aging that monotype implants are more fracture resistant than 2 pieces. And that's why, because monotype implants doesn't have the micro space or micro gap between the abutment and the implant itself, so would give it more solidity. Also, fracture resistance can be affected by implant design, which is again related to the monotype or 2 pieces, the material, which is zirconia, or is zirconia is sandblasted or sandblasted acid etched, and the abutment preparation, which has a negative impact on monotype implants only, because with monotype implants, we need to prepare the cervical part of the implant, and that preparation could have an impact on the fracture resistance. Finally, further research is required to find efficient aging and loading condition for 2-piece implants. So till today, we are still finding ways on how to deal with 2-piece implants. As we said, the monotype implants is more fracture resistance. Now, implant survival rate and success rate. And here we have a bit of mixed up terms. So the implant survival rate is totally different than the success rate. When we're talking about the implant survival rate, we can say that survival rate is defined as the implant is still being there in the patient's mouth on the day of examination. No matter what the patient, the implant has problems. So if it has peri-implantitis or it's not functional, like an implant could be on the mandible without even have any prosthesis or any crowns, but still the survival rate, it didn't fill out. While the success rate means that the implant is functional and the patient is satisfied at a particular time. So if we did a study of 3 years, the implant should be success all the period. However, the survival rate could be for 10 years and the implant could have a lot of problems during this period. So now the studies we're going to evaluate the survival rate, the success rate alone. And this is a bit of downside for zirconia because we don't have long-term studies up to more than 5 years for zirconia, while in titanium, we have it up to 10 years. So I tried to just compare between the two in a similar periods. So up to 5 years of follow-up, titanium implants shows 95% to 97% of survival rate. In comparison, the 3 years prospective study illustrated that zirconia implants replacing single tooth had survival rate of 97.5. So here, in 5 years, for single crown, we have from 95 to 97, and here we have it 97. Now, for success rate, we have a 10-year retrospective study, about 511 implants, on average of 48 patients. Success rate was 97%, while the success rate of zirconia up to 40 years retrospective study on 15,000 implants was 96 to 98. Yeah, it might be only 4 years, however, it's more implants. And again, another 5-year follow-up, 800 implants, only in zirconia, the success rate was 95%. Again, 3-year prospective study, 44 implants, zirconia, success rate 97. So despite that, we don't have a long-term follow-up studies, we still able to say that zirconia has a similar percentage of success rate and survival rate to titanium. Now, the zirconia evolution, we started with, in the 1970s, with Olumnia, and it was one-piece implant, monotype, and then it was developing that we reached in 2012, and there started a trend towards 2 pieces implants, and now the market can be more orienting into the 2 pieces implants. Why? Because of the flexibility of the procedures. With the monotype, we are so limited. How can we deal and how can we restore our implants? The 2 pieces are giving us more flexibility and more option. And sometimes with surgery, we are limited with the anatomical structures that we might put it in a tilted way or in a wrong way or a not accepted aesthetic way. So the 2 pieces implants can give us solutions. So as summary, we can say that zirconia are giving us aesthetic and it's metal free, which is a lot of patients now are asking for. Osseointegration, we can say that it has the similar features of titanium. For preclinical studies, it has shown that it has pre-implantitis regarding the implant itself. However, we have in vivo studies comparing the abutments and the healing caps between titanium and zirconia, and we could find that zirconia was associated with less percentages of peri-implantitis. Regarding biomechanical fatigue, it has been found minimal, but we are not comparing it against titanium. We compare that itself against zirconia itself. Now, the survival rate and success rate, it has been found similar. Now, regarding the downsides, we only have limited clinical data, so further clinical studies are required. Not every manufacturer provide evidence-based data, which would cause us a lot of problems when we are picking or choosing which system or company we are going to deal with, because without evidence-based data or clinical trials, we're not able to judge if this is working or not. Again, the monotype implants have less flexibility with restorations, and that will also would cause a lot of complications for the dentist. We finished from comparing between titanium and zirconia, and as been requested by Dr. Anas, he would like me to mention the root analog zirconia implants, which is a bit something usually is not mentioned, usually is not discussed between dentists, and maybe for some people, maybe they don't know that it's there. So root analog zirconia implants, in a brief, because of today looking for those using ceramic and anatomically oriented implant designs, new biomaterials and surface technology has resulted in dental implants that are specially designed to replace each individual tooth itself. And considering the prevalent knowledge of clinical dental implant practice and the screw dental implants and the need for augmentation, that is not making anything easy. And using CAD/CAM, root analog zirconia has become something more feasible and reliable. So if we started, we can say that in 1969, this idea came up, and it was established for re-establishing the physiological peri-implant conditions, which is fitting and filling the alveolar socket after removing the teeth. And also stress distribution, because the morphology of the tooth itself has stress distribution, while the implant, which has like a screw tapered shape, does not have this distribution. And also the aesthetic that can give for the socket, for the alveolar socket. So the advantage of this root analog zirconia implants are easy fitting with immediate tooth replacement, which can be also at the same time a downside that we will come for later. It's also minimally invasive because we don't need to do any osteotomy because the socket is kind of shaped and is ready to receive the implant. And also it reduces the number of surgeries, and there's only can be one surgery that it fitted. The disadvantages are extracted teeth or the extracted tooth should be in a specific situation to be able to receive an immediate implant after removing the tooth. So it should be periodontally healthy. The extraction should be minimally atraumatic. There should be sufficient bone support. So if when we are extracted, we remove the buccal bone or the buccal cortical area, that would make a problem. Absence of any periapical pathology, that in some clinical cases, after looking through the root analog zirconia implants, that was not really a problem because after cleaning and not immediately placing the implants, that was a bit fine. Now, limiting the prosthodontic solutions, it's the same problem with the monotype because when we are making the root analog zirconia, we are making it as a monotype implant. This is a case report, and it's a 50-year-old female patient, had the lower 6 being extracted. And after 1 week, after the healing of the socket, the tooth being glued because there was like a fracture in the mesial root, laser scanned, and then they made out of a block of zirconia, the tooth, they put a bit of micro retention additions in the root to increase the retention of the tooth. And this is after, that was after 4 months, and this is after 2 years, which is a good result aesthetically and bone integration. So we can say that the successful clinical study suggests that further clinical research and RCTs, randomized controlled trials, are worth it to evaluate the long-term success rate of root analog zirconia. So that doesn't mean that root analog zirconia implants are really working. That means there is a potential that we need to investigate. Also, the use of CAD/CAM had really made immediate tooth replacement is something way better, feasible and reliable. And also, this geometrical mimicking of the socket is able to distribute the stresses through the bone, and this results in decreasing early peri-implantitis. Further studies again is needed in zirconia itself. Now I need to mention something about fitting the tooth in the socket in the immediate placement. There's a study saying that the space or the void between the tooth and the socket should not be more than 2.5 millimeter. And if it was a bit more, that would not have a potential best outcome. And this is where the failures can happen. Now, we have a dilemma here. Sometimes you're taking the teeth out, you do the CPCT, and then you want the scanning, and then you have the patient after 1 week. In this time determined, the alveolar socket already would have remodeling. And this is when they are making the root analog zirconia, mimicking the tooth shape However, it's not same to the size because it needs to fit again. And these are the steps and the dilemmas that need to go further in the studies to find the best steps, how to go through everything bit by bit and how to find the best outcome for the patient. And those are the references. Thanks for your attention. And this has been my activities during my quarantine here in Manchester. Thank you.
شكرا كثير دكتور شوكت على البرزنتيشن الجميل. بتشكرك جدا. ما بعرف الاستاذ الدكتور باسل براد. We are thankful for you, Dr. Shaukat. I'm wondering, Dr. Basil Brad, maybe have some questions before picking and grabbing the questions from the internet on the Facebook. Dr. Brad, you can start, please.
بتشكرك دكتور شوكت على العرض الجميل. Thank you for your interesting presentation. And I would have one question for you. Is which type of treatment, if you suggest that the zirconia is analog for a root, which treatment technique would you have to apply for the surface of the zirconia?
So according to the literature and according to the many studies that I have looked at, apparently the zirconia that being made by Stroman, and the trademark is ZLA, which is self-etched, large gritting, and acid-etched. That was the best, that was associated with the best outcomes in many studies. But as I said again, not all companies have enough studies to justify which is the best. However, just according to the clinical studies, that you can say this is better than this. And that's our problem with titanium. We have about 10 years follow-up and more. There is 18 years actually. But with zirconia, there is no more than 3 years, even in Switzerland and Germany. Maybe by now, there is about 5 years. That if like they started maybe in 2017, they had one that has been for 3 years. So if we can count with now, it would be about 5 years. But I can say, this is not something that I mentioned in my presentation. In the past, we started with amalgam. Now we are dealing with composite and everything is composite. So it could be in the past it was titanium and today it's only or going to be only zirconia.
Oh, that you mean you expect a good future for zirconia to replace the titanium?
The share market in Germany and Switzerland shows that in 2025 there would be more than 50% of the market just for zirconia, and the titanium is going down. Also, there was a survey that I could not really find, but I know about because I saw a lecture and conference, and they were saying that in a survey in Switzerland and Germany, I think, 35 patients preferred to have zirconia in front of 5 that wanted titanium. The others had no difference. So there are more trend towards patients who are saying metal-free and aesthetically, and they would like the white color implants. So yeah, I believe that the market will go to zirconia in the future.
I believe also the same, and I hope that.
Yeah, me too.
Thank you very much.
No problem.
Finish the mic with you, Anas.
Yeah, Dr. Brad, thank you a lot. Thank you, Dr. Shaukat, but I have some little questions. The first question is, do you imagine that away from one-piece implant, we can get two-piece implant like 3 and 2 millimeters without any tulip fracture in the neck of the implant, if it's zirconia, for example?
Again, please. Do I think?
I'm asking about the narrow type of zirconia implant. Could we have in the future like narrow type of titanium implant without a tulip fracture on the neck of the implant?
Okay, so all the studies that being investigated now, there was on 3.8 to 4.1 measurement.
One piece or two pieces you are mentioning?
There was one pieces and there's a bit of two pieces. However,
So
when you are mentioning the narrow implant, you are talking about 3.0 or 2.7?
yeah, 3.0,
Mini
3.2
implant.
with two pieces. So the neck will be very, very narrow, and we know that zirconia is very brittle type. So as a two pieces of implant, I'm thinking that in the future, if they added something to the zirconia to be not as stiff as it is, so maybe it could be survived.
So as I mentioned before, the fracture resistance in the monotype was greater in more than the two pieces. And that was the downside of two pieces. So later in the future, I'm sure they are working on something now to overcome this downside, but I did not find a lot of studies, because even the study that I found, which was in 2020, and it was a systematic review, it was still insisting in monotype has more fracture resistance than the two pieces implant.
Yeah, the second question is that zirconia material, the zirconium oxide, through helping my colleagues like Dr. Mansour Abu Qassab, he was studying for bridges on zirconia. Zirconia bridges and any zirconia material, it's not stable in the nature as titanium. It has some radiation. It has some chemical changes during inside the mouth of the patient. Do you think that as an implant touching directly the bone, we will not have any problems in the future with zirconia implants?
So as I mentioned, the problem with the zirconia is the metastability. So the zirconia material itself is a metastable material, and it can transform between the monoclinic and the tetragonal phase.
Yeah.
And they added a compound called ITRA, which is Y3O2, and they use it in a lot of manufacturing. And this managed to make the tetragonal phase stable. However, that has the downside of aging. And when they studied the aging, they found that it has a minimal effect on that. So let me a bit of explain more. So why does really the tetragonal is better than the monoclinic? In the crystal structures of the zirconia itself, whenever there is this micro cracking and it opens like that, the monoclinic structure of the zirconia get expanded. And by pushing, it closed the micro cracking. And that's why they want the whole zirconia to be in the tetragonal, and that around the microstructure, a micro cracking, to be only monoclinic. So it expand and close again the micro cracking. So when they are studying the aging effect and this problem in zirconia, they found that even after time, if 60 years, they found the impact was minimum. And even they found that it was like 1.4 micrometer from the surface. So it was the depth of that grain or this transformation was not that huge. Now, I don't want to go deep in chemistry and manufacturing, but if that's what we are concerned about, this is what they are working on.
Yeah. The second thing is, do you feel that zirconia implant has more advantages in the posterior area? In the anterior area, maybe it will be benefit because of not the gray style, grayish color could happen. But in the posterior area, does zirconia implant is better than titanium or advisable to be saved in the future? And what about the peri-implantitis surrounding zirconia implants?
See, if we want to discuss the osteointegration or the peri-implantitis, we are still not sure if really the zirconia is better than titanium. With peri-implantitis, preclinical studies are showing that it's better. Now, aesthetically, we don't need it in the posterior area. Why?
Yeah, sometimes, but sometimes we are putting an implant, grafting in the session of implantation, and regraft again in the session of making the prosthesis. Do the grafts will stuck to the zirconia implant like what we have or what we face in titanium implant? Hydroxyapatite treating, acid etched, large gritted.
So according to the current studies, it's showing that it's working. but more studies are needed. So that's the difference between titanium. When we are talking about titanium, we have studies, we have the evidence to say, yeah, it's working. Now, today, we are saying that if you want to do sinus segmentation and you put a zirconia, after 3 years, it's there. However, is it there for 10 years? Is the problem was with the stress distribution? Is it with loading? Is it with excessive loading? It's failing? There is those questions that is still not certain or not known, because further clinical studies are needed in a different way. But because zirconia is still a new material, not a lot of RCTs are able to achieve it.
About the root shape like implants,
Yeah.
do you feel that it's really could be repeatable easily with a way of advanced skill? And what's going to happen inside the socket? Because sometimes we need scanner, we need milling. You know that centering the zirconia takes 10 or 9 hours. What's the dehiscence and the deterioration is going to be inside the socket for these implants? And even more, that the buccal plate is very thin in the anterior area. Do you imagine that root shape like implant could be used in the anterior area like aesthetic zone with very thin buccal plate?
So there are studies trying to put the implants in the interior area. Now, not most of the studies, because there's not a lot of studies, none of them were placing the implant immediately after extraction of the tooth. However, the implants were placed after 1 week or 2 weeks. And that's the closure or the fitting of the implant with the periodontal socket or the alveolar socket. And this is the whole point of the root analog implant, is to prevent the alveolar socket resorption. So I'm not sure exactly, because still there's a lot to look at that and to study it, because I believe there was a study in I cannot remember exactly, but there was a study that was like 100% fail of all the implant that being placed. And that is just like now a huge drawback to go through this again. But the case report, which is the weakest evidence in the pyramid of evidence, is showing a bit of success. However, there is no real steps or there is no real protocol to go through so you can try it.
Dr. Shaukat, I wonder if Dr. Brad hope to say something, a comment on what we were discussing. Dr. Brad.
Okay, I want moment. Is it okay? You hear me?
Yeah, we are hearing you.
Good. I want to thank everyone, Professor Julian Yatis, Dr. Muhammad Badr, Dr. Shaukat Chiti, for accepting our invitation in this meeting, scientific meeting. And I hope that this meeting will repeat itself more and more. I hope in the future that we meet you face to face, not only virtual, in Manchester or in Damascus, hopefully.
By the way, I've done my internship here in Damascus University, and I graduated from the Syrian private university.
Oh, very well. We are proud of you.
Thank you.
فخورين فيك دكتور شوكات. And I thank Dr. Anas for this arrangement, for this management of this meeting, and would to say bye-bye. See you again.
Thank you.
Bye-bye.
شكرا كثير دكتور براد، شكرا كثير دكتور شوكات. Thank you of all lecturers. Thanks for Manchester University. Thanks for this meeting crossing the border. Thank you, Dr. Shaukat. You were great in arrangements and making the contact with the professors there. Thank you, Dr. Brad, for accepting to be a major part in this meeting. We need really your experience here. Thank you a lot. And we hope that maybe we can make a conference or another meeting in the future. Thank you, Shaukat. Thank you a lot. You can say, if you want to say something, Dr.
I want to thank our followers, our students, our colleagues. They were with us for the 3 hours. Thank you for their patience also.
That's right, Dr. Brad. Thank you all. Thank you, audiences. Thank you, Dr. Shaukat. Thank you a lot for the next meeting. We are waiting and looking forward for more participation. Thank you all. Bye-bye.
Bye.